Will some AV team prompt you or?
No, I am the AV team. We are live.
Okay, so as we are all
okay, welcome and good morning to each and every one of you. This is from AMRITA Hospitals under the aegis of Cochin Ophthalmic Club and Kerala Society of Ophthalmic Surgeons. We are having this particular meeting today on AMD update. What everyone, each and every one of us should know about with AMD is what we'll be discussing today. So welcome all of you. We have Dr. Lalit Verma as the person who is chairing this meeting. He, after each talk, will have a small 5-minute discussion and take down the key points from that particular talk. We have otherwise right from etiopathogenesis, which Dr. Pooja is covering, to further on investigations in AMD, in which fluorescent, ICG, OCT angiography, the different biomarkers will be discussed. And retinal fluid is a very, very important thing, which Dr. Vasumati Vedantam will be talking on. And then we will have OCT angiography, Dr. Neha Goyal. And then we will have our keynote lecture by none other than Dr. Dinesh Talwar, who will be speaking us on optimizing the management of AMD. And finally, we have some brolucizumab experiences, Dr. Prashant Bhavankule and Dr. Shubhendu Boral. This is our team today. So in about 3 to 4 hours, I think all of you will get a 360-degree overview of what everyone should know about AMD. Over to you, Arup sir, for your inaugurating this event.
Good morning, friends, and congratulations, Gopal, for this curtain raiser program for AMRITA. AMRITA, gives very good programs year after year, and this is under the aegis of COC and KSOS. That is the reason I figure in here. And I see a lot of stalwarts here. Dr. Lalit Verma, sir, doesn't require any introduction. We have Dr. Dinesh Talwar, the national faculties, and then we have Dr. Vasumati, we have Dr. Prashant, Dr. Shubhendu Boral. So a warm welcome to all of you for this program. And then of course we have up and coming stalwarts from our own state. So as you know, this is I think the second program being conducted under the aegis of KSOS, first academic program. And let us have a fantastic beginning to our academic program. This is the curtain raiser. And we have planned a lot of events for KSOS over the next year. And more about it will be discussed in subsequent meetings. And with these words, I would like to welcome all of you, all the speakers, all the delegates who are watching this program online. And this will also be available later on after the program is over on the KSOS YouTube channel. So thank you very much and wish you all the best.
Thank you very much, sir. This is in our new Kerala Society of Ophthalmic Surgeons YouTube channel. And I would urge all of you to subscribe this channel because all our programs will come in this particular channel. Over to Shashikumar sir. Shashikumar sir is a senior ophthalmologist and he is the president of the Cochin Ophthalmic Club. Shashikumar sir, please.
Okay, Gopal, Lalit Verma sir and other delegates and dignitaries. I'm very happy to be part of this CME. COVID has opened the world of digital communication and virtual conferencing. And Gopal is one who has exploited it to the maximum. AMRITA is one of the top universities in India, and Department of Ophthalmology, headed by Dr. Gopal, is one of the many wings of AMRITA, which has helped it remain at the top. The topic for today's CME is Macular AMD, the management of which has been, we have been seeing big strides of late. This CME will give an update of what current ophthalmology provides in the diagnosis and management of AMD. As the president of Cochin Ophthalmic Club, I wish the CME the very best and hope the delegates from around the country and hopefully from around the world will have a fruitful day of learning. Thank you.
Thank you very much, Shashi sir. So I would want to invite Dr. Lalit Verma, my teacher, my mentor, current Vice President of the All India Ophthalmic Society, to take reins and talk about the program and how it will run. Over to you, Dr. Lalit, sir.
Thank you, Gopal. Thank you, Dr. Haroop. Thank you, Dr. Sasikumar, for having me here. You see, the AMD is not an infrequent problem. Ophthalmology, generally, we encounter, geriatric population, and AMD is a frequent, disease of the retina. Like Gopal was saying, our purpose is that we should send out clear-cut messages that, what everybody should know about AMD, whether it is retina surgeon or whether it is...
Sir, 1 second, sir. 1 second, sir. I think is your mobile on and...
My mobile is on.
No, because we are having another voiceover.
Is it okay now?
Having a little lag. Is everybody hearing that?
No, I am not having it.
No, we are not having it.
Oh, sorry.
So somebody would have kept the YouTube also open.
Yeah, that's why. Somebody has kept the YouTube open. Let me see.
You can find out actually. Yeah.
Yeah, otherwise we are okay. I don't hear any echo.
It's only for you, Gopal. I think we are not hearing.
Sure. So let's go ahead.
So
sure,
as I was saying, you see, the purpose of this webinar would be that what everybody should know, not only retinologists, but all eye care providers of anterior segment surgeons should know what can be done today about ARMD. Because it's not, a couple of decades back, we all used to give only B complex or sometimes laser these patients. But today, plethora of agents are available which can improve the vision in these patients. So stitch in time saves 9, people say. So if we diagnose early, not allowing it to reach up to scar level, so then I think a lot can be done. So anterior segment surgeons should always, what I keep saying in all the webinars is, evaluate the degree of cataract, evaluate the posterior segment pathology, also see for, any macular pathologies, so that they do not face, surprises after cataract surgery that patient is not improved. Believe me, in any OPD, what I have seen is 15 to 20% of general this thing will have some retina issue. So ARMD is one of them. So we will try our best to have, some take-home messages after each point. Although honestly speaking, we do not understand the exact cause or, pathogenesis, but we have a lot of treatment modalities definitely there. So, but we will discuss role of imaging, role of, biomarkers, and then what is currently available, what future has in scope for us. So 2 things I would like very loudly. One is what everybody should know, and secondly, clear-cut messages for all the listeners and colleagues, especially the anterior segment. Because I believe a lot of retina people are aware, but I would like that everybody, all ophthalmologists should be aware of these developments in neovascular ARMD. So with this few words, let's go on, because Gopal has, what beauty of this program is, Gopal has given enough time to everybody to speak. It's not a 7 minutes talk. It is abundant time for Pooja and everybody, subsequent speakers. So let's start, Pooja, with your presentation. And yes, she will be telling us about etiopathogenesis and pathology of AMD. So this will lay the foundation for understanding each and every subsequent talks.
Are you able to see my screen, sir?
Yeah. We can hear and everything is very good. You can carry on.
So good morning, everyone. Thank you for giving me this opportunity. Today, I'll be talking about the epidemiology, etiopathogenesis, and pathology in AMD. So what is AMD? It's a complex disease with genetic and environmental etiology playing a major role, and it is a leading cause of irreversible blindness. There are many studies done in ARMD, out of which the Beaver Dam study stated that the prevalence of advanced ARMD accounted for 1.2%, geographical atrophy accounting for 0.6%. Framingham Eye study showed that the prevalence of advanced ARMD is 1.5%. The prevalence rate of AMD among the Europeans is 12.33%, Asians 7.3%, and Africans is 7.53%. More than 3.4% of the Indian adults have been over 65 years of age are affected by ARMD. Global prevalence is 10.13% of the adults over 65 years of age are affected by ARMD. Overall global prevalence is 8.7%. It is seen that more than 50% increase in the number of cases by 2040 to 288 million has been estimated. The increasing prevalence associated with aging group of global population has been noted. We know that the ARMD is of two types, dry and wet. Dry ARMD accounts for 85%, neovascular AMD to 15% of cases. Even though neovascular AMD accounts for only 15% of the cases, however, 90% of AMD associated vision loss is because of neovascular AMD. This is the predicted global prevalence of AMD by 2040, which states that there are about 113 million people affected in the Asian population, followed by 69 million in the European population. Coming to the risk factors, we all know that age is a major risk factor. Basically, what is happening with age? There are two changes that we see. One is vascular changes with age and structural changes with age. What are the vascular changes that we see with age? There is decreased choroidal thickness, decreased choriocapillary density, decreased lumen diameter of the choriocapillaries. This will lead to increased resistance to flow, thereby reducing the choroidal flow and choroidal perforation. So these are the vascular changes that we see with ARMD. And with age, with structural changes in ARMD that we see are senescence of RP. RP plays an important role in the pump mechanism. If there are senescence of RP, there is a lot of accumulation of waste products in the form of drusins. There is thickening of Bruch's membrane, changes in the composition of Bruch's membrane in the form of stiffening. This leads to changes in the extracellular matrix, increase in the oxidative stress. All these changes, along with genetic predisposition and environmental risk factors, lead to ARMD. So I would like to add a few points here on genetics. CFH and HTRA1 loci are the two major loci associated with ARMD. Even though there are a lot of 103 AMD associated loci identified, the major ones are CFH and HTRA1 loci. Coming to the gender. All the studies stated that there is equal prevalence between males and females. However, the Blue Mountain study and ARETS study stated that females are more commonly affected than males. Race, it is noted that whites are more affected than blacks. This is because of melanin, which has a protective role in ARMD. If a person is affected with ARMD, in the family history, there is fourfold high risk of developing ARMD with among the family members. Smoking is also an important risk factor in the development of ARMD. If a patient is having an intermediate or an advanced AMD, vitamin C, E, beta carotene, and zinc supplementation will help in reducing the development of ARMD in the other eye by 25%. The markers of inflammation such as C-reactive protein has a higher risk of developing ARMD. When we come to Indian scenario, this is a study done by Kulkarni et al. In a hospital-based study in Maharashtra. They stated that females, high BMI, history of cigarette smoking had important risk factors in the development of ARMD. These are the other studies. Indian studies include Krishnaya et al., which is a community-based study which totaled the proportion of ARMD to be 8.9%. Gupta et al. And Agashi et al., these are also Indian studies which stated that it's around 1.4 and 1.3. Coming to the pathophysiology, what do we see in ARMD? It is the disease of the macula and it has one of the following, characterized by one or more of the following features. There's first accumulation of drusen, so there's drusen formation, retinal pigment epithelium abnormalities in the form of hypo or hyperpigmentation, end stages like geographical atrophy of the RP or the choriocapillaries, and neovascular maculopathy. The three major theories that explain the development of ARMD is traditional theory, vascular theory, and oxidative stress theory. The traditional theory says that there is senescence of RP. RP, as I told you, RP plays an important role. So since the RP is aged, there is development of metabolic debris in the form of drusins, and this leads to thickening of Bruch's membrane is noted, which leads to crack formation and the growth of the CNVM component into the subretinal space. Steen proposed that CNVM could develop in response to fragmentation of the Bruch's membrane relating to the matrix metalloproteases, which may play an important role in angiogenesis and CNVM formation. Vascular endothelial growth factors, tumors growth factor, and platelet-derived growth factor also play an important role. The most accepted theory is vascular theory by Friedman, which says that there is decreased compliance of the ocular tissue with age, thereby increasing the resistance of ocular circulation. This can be in the form of either decreased choroidal perforation or increased choriocapillary pressure. If there is decreased choroidal perforation, there is impaired clearance of choriocapillaries and lipoproteins secreted by the RP, leading to drusen formation. And this decreased choroidal perforation can lead to geographical atrophy. This is one end of the, that is the dry ARMD component. If there is increased choriocapillary pressure, there is and associated with calcification and fragmentation of the Bruch's membrane, stimulating the CNVM to grow into the subretinal space, leading to choroidal neovascular component. This vascular theory has a stronger major strengths like this explains the epidemiology, the pathology of ARMD. It also tells us that the atherosclerotic risk factors in general, and especially the systemic hypertension as risk factors, and antihypertension is a protective factor. Coming to the oxidative insults. Macular pigments account for relative resistance of the central fovea against the degenerative change. They basically limit the oxidative insults, the filtering of the harmful wavelengths of light. How does retinal pigment epithelial detachments occur in ARMD? The reason for this also is the senescence of the RP cells. They don't effectively function, leading to the development of serous fluid or fibrovascular component under the RP, leading to pigment epithelial detachments. To summarize, so we have aging, genetic and oxidative damage acting as a major risk factors, leading to the damage of the insufficient tissue repair or damage of the tissues. This leads to buildup of waste material. The buildup of waste material in the form of drusens or amyloid deposition. This can lead to complement activation or inflammatory activation, and finally lead to the development of RPE damage. In ARMD, the visual impairment can be because of atrophic ARMD or wet ARMD. In atrophic ARMD, it is the RP atrophy that finally leads to visual impairment. So how does this RP atrophy occur? Because of this drusen deposition, complement activation, inflammatory activation, all these lead to the RP damage, leading to RP atrophy. The RP damage can also, because it's part of blood-retinal barrier, there is a breakdown in the blood-retinal barrier, leukocyte recruitment, leading to the development of CNVM and the macular exudates, and it also leads to subretinal fibrosis in the wet component part of the ARMD, leading to visual impairment. So this is how we see. This is a normal retina showing us the optic disc. This is the center macular area. When we see here, this is a normal fundus. So you can see the actual arrangement of the proper arrangement of the photoreceptors, the normal RPE, Bruch's membrane, and the choroid. In dry ARMD, what is happening is, as you can see in this picture, there is some amount of yellowish deposits. These are the drusens. So where exactly are these being accumulated? These are being accumulated between the RP and the Bruch's membrane, as you can see in this picture. So how do you look in a clinically? They're soft, confluent drusen throughout the macula with sub-RP dropouts. Now coming to the wet ARMD, you have early and late. As you can see here, there is drusen deposition as well as the choroidal neovascular membrane has grown through the cracks in the Bruch's membrane and underlying the RP. How do you see clinically? It is seen as acute subretinal blood in the macular area with subtle subretinal fluid, but however, the CNVM component is not so clinically visible. In the late wet ARMD, as you can see in this picture, it has grown. Some amount of bleeding is also there. This clinically, how do you see? It's seen as subretinal blood. CNVM is a greenish component along with some amount of subretinal fibrosis and hemorrhages. The age AREDS classification of AMD is divided into 4 categories. That is category 1, which is no AMD with no or few small drusens, the size of the drusen being less than 63 microns in diameter. Early AMD, that is category 2, has multiple small drusens, intermediate drusens, or RP abnormalities. Intermediate drusen size being 63 to 124 microns in diameter. How do you compare the size? It is already known that we always compare with the size of the vessel exiting from the optic disc. When we compare with that size, we'll know the size of the drusens that are present in the fundus. Coming to the intermediate drusens, the intermediate AMD, it is category 3, where you can have extensive intermediate drusens, at least one large drusen or a geographical atrophy not involving the center of the fovea. Advanced AMD, that is category 4, one of the following will be there: it has two components, either the atrophic component or the vascular component, neovascular component. The atrophic component is a geographical atrophy of the RP and the choriocapillaries involving the center of the fovea, and the neovascular maculopathy involving the CNVM or the serous or hemorrhagic PED, or in the form of retinal hard exudates, a secondary phenomenon resulting from chronic leakage from any source, subretinal or sub-RP fibrovascular proliferation, or a disciform scar. So these are the images I want to These are the images I want to highlight. This is the image, fundus image of the right eye, where you can see an extensive geographical atrophy. And this is an image showing the wet component ARMD, where you have some amount of bleed. You can have the CNVM component and some amount of exudation. Thank you.
Thank you, Pooja, for this telling us the pathogenesis of very ill understood kind of entity. As I said, you see, pathogenesis is actually ill understood. That is the reason there are theories and theories. See, you mentioned about vascular theory, oxidative theory, and sensorence, and so many other things. But a couple of take home, I think, which everybody should know, like Dr. Gopal had said in the beginning, what everybody should know. To my thinking from your talk, I think these risk factors everybody should know. So those are the things which everybody can implement. Things like smoking. At least you can tell. Other things, I think one of the things I think which I was wanting was high BP also is one of the which I tell all my patients that BP should be under control, and excessive of sunlight and smoking. These three things are controllable things which do help in. And the second important take home is about the iridis, this thing where, like you said very rightly, that if we follow that iridis formulation in high risk patients, then there is possible that 25% reduction of progress. So these are the two things. The problem is what I see in our practice, I think Gopal can talk about it, is that people will write any kind of vitamin, any kind of, whosoever they are tally with, any kind of medical representative, then none of them are conforming to the iridis formulation. So that is the issue. And today with government putting a ban, there were a couple of, tablets and capsules available which were conforming to iridis formulation. But government did not recently, for a year or so, have banned this excessive dosaging. Gopal?
Yes, I agree with that. So a couple of things that I wanted to bolster would be, one is hereditary nature of it. Like if somebody in the family has it, there's a 4 times higher risk. Many times when an older person comes, their 60-year-old son or daughter will ask, will we get it? So there's about 4 times chance of that. Number 2 is we should always educate the patients that aging cannot be reversed. So this is not a disease which we treat and everything will be all right. So this is a continued aging process which we are trying to arrest. And so you should not be, the person should not be thinking that, just give this injection, everything is going to be all right, it's going to be reversed and back to what I was at 20 years. But that is a thought process which patients usually come to us with. So that education, that this is an aging process, this will continue to worsen over the next 10 years. And we need to continue to treat you over the next 10 years to at least give you the visual acuity that is navigational, is what we should be telling the patients. Thank you.
Yeah, I agree, because we may not be able to ultimately, prevent everything, but at least for lifelong, he will have reasonably good navigational vision all through his life. That is important to tell. So another point, Pooja, would you like to make? Because apart from what I said, risk factors, Gopal also elaborated on family.
Ocular cause, definitely. Hypermetropia is a risk factor when compared to myopes. Only that point I wanted to add.
So the lesson to be learned from Pooja's talk is risk factors should be known to all, like family history, smoking, BP. Somehow this C-reactive protein, we routinely don't do it. And the antioxidant index, you see, I know of people in the US where Gopal family history, they will do mapping and all these things and then identify people and coach. But let's talk about India only. What we do is this only, and also tell these patients that if you cooperate and if you report early, before, like last slide was very good, that we don't want that left side, we don't want disease to go up to the scar stage. So whatever good vision is possible nowadays, we will try our best to do it. So I think 2-3 messages have gone very clearly from Pooja's talk. Let's move on to the next talk about the role of FA and autofluorescence and ICG. Dr. Prakash.
Prakash is a senior consultant at Calicut Compressed Eye Hospital, a well-known retinal surgeon. So Prakash, first, most of the patients will come with either asymptomatically only for a general checkup, or their one eye is already lost to AMD, the other eye we are going to follow up, or the patient may come with a decrease of vision or a scotoma or a metamorphopsia or something like that. And the first investigations that we're going to do is imaging, and Prakash is out there to talk to us about that.
Thank you, Gopal, and very warm good morning to all of you, and my respects to Lalit Verma sir. So my talk is on FAF, FFA, and ICG in age-related macular degeneration. So basically, these are photographic techniques in AMD compared to the scanning methods like OCT. How is it done? Is basically using conventional light or monochromatic light like blue, green, or single wavelength lights, or a scanning laser ophthalmoscope may be used to capture the images so that you get better quality of picture. And we use in all these modalities what is known as a property of substances to absorb a certain wavelength and emit back a certain wavelength that is known as fluorescence. This can be autofluorescence if it is the same particles present in one's own eye that is doing this fluorescence job. Or if it is induced by dyes, then we call it angiography. So what they do basically is enhance the lesions of age-related macular degeneration so we understand it better. Because AMD is a disease with multiple components. Also, it gives an exact topographic location, even up to periphery, which is not usually done by a OCT-based imaging. The biochemical composition, whether it is phospholipid, neutral lipid, this kind of idea also it gives. Structural elements, vascular, fibrous, tissue. This also it gives better than a scan-based imaging system. Also, other deposits, if they are present, it will highlight those tissues. So through this talk, I'll be talking only about this, even though we have a lot of imaging modalities. I'll be going only through ICG, FAF, and FFA, and we'll be looking at patterns, various patterns in dry and wet AMD, and in what role do they play in the current scenario, where OCT has almost hijacked our imaging modalities in AMD. So going through dry, we'll start with dry AMD and look at the imaging in this. So we have fundus autofluorescence. That's what I've been asked to talk about. This is basically blue wave FAF or short wave FAF, what I'm talking about in this talk. This is produced by the fluorophore. That is the material that causing this fluorescence is basically lipofuscin. It is a photoreceptor outer segment degradation product that get collected in the retinal pigment epithelium. And the chemical known as bisretinoid produces this fluorescence. It has the property of absorbing blue light at 490 and emitting yellow-green light at 610 nanometer. And they are concentrated maximum at posterior pole around the fovea. How does a normal image look like? It can be captured by either a light-based fundus camera or a better with CSLO or even a wide field imaging can be done. So the macula center looks actually hypo. That's one of its drawback compared to its rival NIR imaging, where this is because the xanthophyll blocks the fluorescence. So the macular center appears dark. Rest of the areas are seen a grayish white, which shows a good or normal or an isofluorescence. And in abnormal fluorescence caused by either change in amount of lipofuscin or composition of lipofuscin or presence of other autofluorescent material either in front of the RP or behind the RP or abnormal tissues with similar to RP lipofuscin or media opacity. So this can cause abnormal photofluorescence, and how do we interpret it? So the basically clinical role in AMD, as Dr. Pooja has told, she has clearly told us the pathogenesis of AMD, and lipofuscin deposition in retinal pigment epithelial cells follows a parallel mechanism, just like the other toxic materials that get accumulated in the retinal pigment epithelial cells in AMD. That's why the shortwave autofluorescence, fundus autofluorescence using lipofuscin has a it's a very strong predictor of progression in AMD. It's a very non-invasive method of diagnosing dry AMD. So it has a higher use compared to dye-based angiography as far as dry AMD is concerned. So we all know from Dr. Pooja's talk, drusen is the hallmark of dry AMD. But you have to remember, drusen is not just a component of AMD alone. It can happen in other diseases, one thing. Second thing is drusen. There are different type of drusen with different types of prognosis and different clinical features. So that we have to distinguish by using the imaging modalities we have, FAF as well as dye-based angiography. So as Dr. Pooja told, these are the most common form of drusen, what we known as hard drusen, less than 63 micron in size, discrete small lesions, which can be present at macula. It can be present in periphery also, most seen in the parafoveal, perifoveal areas, and in fundus autofluorescence, sorry. So in FAF, you see that lesions, all of these lesions are not, most of them are hypo or isofluorescent, but some of them are hyperfluorescent. Then comes a more specific lesion of dry AMD, that is a soft drusen. These are larger than 125 microns, and they are usually confined to the foveal area, and they coalesce to form what is known as drusenoid PED, later goes for geographic atrophy. So these are seen as hypo-autofluorescent lesions on most of the time on FAF as well as fluorescent angiography. So these non-AMD drusen, there can be deposits just like drusen in non-AMD condition like macular dystrophies. Here you see most of the time these enhance they show hyper-autofluorescence on FAF. That's one way of differentiating non-AMD drusen. And again, angiography also can be, most of the time I told you these are hypo-autofluorescent on fluorescent angiography, but in this case you can see that these lesions are actually hyper-autofluorescent, actually increasing in late phases. So this depends on the component. This is what I told I meant by the understanding the composition of the material. So here you can see this is hyperfluorescent because increased phospholipids, if it is present in the drusen, it causes hyper-autofluorescence, where if it is neutral lipids, that is more in the soft drusen, then they show hypo-autofluorescence. So that way we can understand what is the material inside. And as I told, there are different types of drusen. So this is all drusen does not mean AMD. This is what is known as cuticular drusen. It has different names: diffuse drusen, basal laminar drusen, or early onset adult onset group drusen. So these can be present. If you see this, you have to look for a renal function of these patients, because this can be representative of type 2 MPGN or C3 glomerulonephritis in that patient. So these are basically clinically very little visible, but if you look at the angiography, you see starry sky appearance clustered around the fovea. So this is because these lesions are conical lesions with apex losing RPE. So they cause this transmitted fluorescence in the early phase itself. So you see this early phase starry sky appearance. So that's very typical. And if you look at the FAF, they are not seen on the FAF. They are seen more hypo actually. But there are multiple small pinpoint lesions appearing elsewhere. So those lesions which are seen, it's actually inverse of FFA. You see what those lesions which are hyper on FFA are hypo on fundus autofluorescence. So that way you can diagnose this condition. Another important type of drusen that you have to look out for is reticular pseudodrusen, STD. 3 phenotypes are described: the dot pseudodrusen, ribbon pseudodrusen, and peripheral pseudodrusen, which is very common, not very common. And in near infrared imaging is more useful than FAF in this case. And see, this is a dot pseudodrusen type, very common phenotype that we see. Usually, this actually the pattern of deposition follows what we see the hydroxychloroquine toxicity also. So this is actually on the superior portion of the macula. And you see that on FAF, it is very clearly seen. These lesions are clearly seen, but in the green photograph, red-free photograph, it is not very well seen. And what is important about this tumor, and in FFA, you cannot see these lesions very well as in. So this is almost opposite of cuticular drusen. FFA does not pick up, FAF picks up well. So what is important is this is very high risk type of drusen, which can go for AMD, very neovascular AMD very soon. And RAP lesion, here we can see what is seen as a RAP lesion. This is actually, this type of drusen are more associated with type 3 MNV or RAP when they produce neovascular complications. So that is how you differentiate. And after drusen, the next most common cause of vision loss in AMD is macular atrophy. So this is actually what happens over a period of time. There is RPE loss. There is pigmentation developing. So pigmentation and diffuse RPE loss is the hallmark features of macular atrophy later when they coil. So here you can see in the picture, you can see multiple window defects other than the drusen that you see here. Actually, the drusens are seen as hypopigment deposits here, hypo areas, and you see the diffuse window defect. So that is the beginning of macular atrophy. Later it progresses. Here you can see extensive macular atrophy, and many of them are already coalescing. When it is more than 175 microns and it is well-defined borders, we call it as geographic atrophy. So that is one of the biggest causes of loss of vision in dry AMD. Now, this FAM study where they have done this fundus autofluorescence in macular atrophy, they have classified into 8 types actually. So one with none, no FAF changes has very slow progression to geographic atrophy, whereas other lesions have more, especially this banded type has rapid progression to vision loss. Then there is a diffuse type again, especially the reticular type, which has very rapid progression. So this helps us to prognosticate the dry AMD vision loss due to dry AMD. And FAF has become the gold standard for measuring geographic atrophy in almost all newer clinical trials because it has a highest correlation with visual acuity. And dye-based angiography in geographic atrophy is used when we suspect a CNVM. You have to remember that CNVM can coexist with geographic atrophy. So you have to, if you suspect a CNVM in a case of geographic atrophy, always do an angiography. But other than that, the role is limited. This is actually one publication where they have shown what is known as dark atrophy. So this helps you to differentiate, because when geographic atrophy need not always be due to AMD, it can be due to macular dystrophies like Stargardt's. So the angiography here, if you compare between the two types, this is early phases, almost similar, but in the late phase, in between, inside the geographic atrophy, you see the bare choroidal vessels clearly, but in FFA or ICG, both there is staining of the in-between tissue. So this dark atrophy tells you, this is a dark atrophy, which tells you it is probably due to macular dystrophy rather than AMD. And we have newer methods, which I'm not covering in this talk: color autofluorescence, near-infrared fundus autofluorescence, quantitative or QAF, and fluorescent lifetime imaging. These are all upcoming imaging modalities for dry AMD. Now coming to neovascular AMD, how do we use this photographic imaging? Actually, in the time of MPS studies and all, we used to define, it was a mainstay. Angiography was a mainstay. Dye-based angiography was a mainstay of studying CNVM. We used to have the subfoveal, extrafoveal, juxtafoveal classification and all. And in PDT, when it came, we had these kind of pictures where we used to measure the greatest linear dimension and the laser spot size around it to calculate the size of laser we have to use. But current role has come down and many people don't use because it's an invasive procedure. And second most disadvantage is that it takes little more. It is not as easy to interpret as an OCT. So, but I still prefer always do as a baseline document. And other indications could be whenever you are giving anti-VEGF injection and you are not getting the response that you are expecting, you suspect some masquerade, some mimickers of AMD, or when you want to do some laser-based treatment for AMD. So we'll just briefly go through the patterns. We have this type 2 macular neovascularization, which is in front of the RP under the sensory retina. You see this classic pattern, that is a lazy filling of the lesion. ICG usually does not show much on in classic CNVM, but sometimes you can see, as in this case, a feeder vessel may be seen. And this is the typical FFA picture. You have the early filling, the mid phase, it is increasing. Both the intensity and the size of the hyperfluorescence is increasing, which we call as a leak. So that shows it is in the under the sensory retina, and that is it is a type 2 CNVM. This is again a more scarred lesion. I can see well-defined lesion, and you can also pick up the atrophy around it on a fluorescein angiography, and you can see the feeder vessel on ICG. And coming to type 1, that is under the RP, sub-RP lesion, you can see the large orangish lesion with X-rays clinically, and on FFA, you see the pinpoint hyperfluorescence, which is increasing, which we used to call as late leak of undetermined source, or LLUS. So this is also known as fibrovascular PED, because you see the ICG shows clearly the vascular network underneath the PED. Now the newer modalities like Octa also clearly show these lesions. And you can see the lesion is mostly under the sub-RP on a structural OCT. Then we have the patterns in type 1 based on ICG, which we call as plaque hyperfluorescence and hotspot. Plaque is nothing but a hyperfluorescence which appears in the late phase and is more than 1 disc diameter in size. In the early phase, you are not seeing this, and this is more than 1 disc, and it's usually tip specific for type 1 macular neovascularization. And another pattern on ICG is hotspot, which is a slightly better hyperfluorescence, but smaller, less than 1 disc diameter, and it's appear in mid phases itself and seen more hyperfluorescent in the late phases. But it is not specific to type 1. It can be seen with type 3, that is RAP, as well as in IPCV. Coming to the third type, that is a type 3 macular neovascularization, where the new vessels start in the retina, inner retina, and progress towards the retinal pigment epithelium and into the choroid. You can see a small, large pigment epithelial detachment. Appearance of a pigment epithelial detachment suggests it is going into the subretinal space. You can see small hard exudates and few dot hemorrhages. So dot hemorrhages always make you suspicious of this lesion. On angiography, this is a typical lesion. At the end of a vessel, you see a hyperfluorescence and a central blocked fluorescence. So that is very typical. You should have seen a hyperfluorescent hotspot in this, but in this angiography, it is in ICG, but it is not seen in this picture. This is what actually meant by the hotspot on ICG. So other than polyps usually along the edge of the PED, this is the PED, this hypofluorescent lesion that you see is the PED. So this is more towards the center. In RAP, the lesion is more towards the center of the PED. So you can see the lesion here on OCT. It clearly shows it is in front of the RP, and it shows the intraretinal fluid. So whenever intraretinal fluid is present and intraretinal hemorrhages are present, always think of RAP lesion or type 2. You can see the Opta also picks up that lesion, small tough. This is a different type 3 MNV. See, this is advantage of angiography. It actually shows what is the pathogenesis, how it happens. You can see in the early pictures a lesion inside the retina, the loop inside the retina, which is going deep. If it is a stereo photograph, it will tell you this is going deep into the retina. And you can see in the late phases, it leaks much severe, much more than a type 3 MNV, suggesting there is a type 2 component now developing. So it has gone from the intraretinal space into the subretinal space, and it's now spreading in the subretinal space. So that is a pathogen. That is how it progresses, the type 3 lesion, and they are usually very refractory to treatment. And the fourth type is a polypoidal choroidal vasculopathy, which many others now call as aneurysmal type 1 MNV, basically a primary abnormality of the choroidal circulation. And you have this kind of polyps. The typical polyps are usually seen around the disc, radiating from the disc in a radial manner, and you can have macular polyps as well as peripheral polyps. So Everest trial had put some criteria for diagnosing this lesion. You have to look at the first 5 minutes of ICG injection, and you have to look for an nodular elevated appearance of polyp on stereoscopic viewing, a hyperfluorescent halo around the nodule, abnormal vascular channel supplying the polyps, we call it BVN, pulsatile filling of polyps in dynamic angiography, orange subretinal nodules, and if massive subretinal hemorrhage more than 4 disc area is present, you should always suspect a polyp. They also describe two types, type 1, which is associated with BVN, and type 2 with a no BVN. So this is a massive subretinal hemorrhage, and you can see in spite of having this hemorrhage, you can pick up the lesion quite well on an ICG angiography, because ICG can penetrate, the wavelength of light used can penetrate the blood very easily, and you can pick up these lesions much better. And we have some biomarkers. These are all publications with small case reports. We don't know the usefulness, but these are certain biomarkers which you should look out for. Choroidal vascular permeability. This is, you can see here CVH is present. The vascular permeability is much more compared to this picture. So if it is present, it predicts a better response to treatment. And late geographic hyperfluorescence, that is in the late phase, very late phase after 10 minutes. In ICG, you see this kind of geographic hyperfluorescent area. Initially, the polyps are seen, but in the late phase, you can see this geographic. If it is present, it suggests high chance of recurrence after PDT, or if intravitreal anti-VEGF drug, high chance of recurrence for these lesions. And if it is present in the other eye, then that eye has a high chance of developing polypoidal PCV lesions as per these studies. And we will look at some components of AMD. Serous pigment epithelial detachment is one such component. Here I put an ICG of the serous pigment epithelial detachment. You see it as hyperfluorescent throughout, even in the late phase. Whereas FFA will show a uniform filling of the homogeneous filling of the pigment epithelial detachment with the dye. Whereas ICG, even in late phase, very late phase, it will appear hypofluorescent. This helps us sometimes to differentiate between a serous PED of CSR, where it becomes in the late phase of ICG, it becomes at least isofluorescent. And one more component of this following PED, especially in type 2 CNVM, is what known as pigment epithelial rip. So you can have spontaneous pigment epithelial rips where you see this area as very hyperfluorescent, whereas secondary to CNVM, since a lot of scar develops, they appear more the staining, and you can see the very clear-cut edges of this rip. And so this is a complication which you have to watch out for when you are doing PDT, focal laser, or even anti-VEGF injections in eyes with large 10 PEDs, tall PEDs. So this has got a poor prognosis if it passes through the center of the macula, if the rib passes through the center of the macula. So after seeing the patterns, I'll just briefly go through what is the current role. Where does it have an edge over OCT? So as I told in my disclaimer, these are not scenarios which we commonly encounter in AMD. These are rarer scenarios, but this is where probably FFA has a better advantage over. So this was one such patient who had undergone multiple intravitreal injection, including aflibercept. There's a tall 10 PEDs. There is SRF on either side, and he has not responded to any of the injections. So at this stage, an angiography was done, and ICG as well as FFA, you can see a polyp which is quite away from this PED. It is not at all near, and there is something like probably a BVN also, and it's far away. So we decided to do a focal laser for that lesion. We treated it with a laser, and you can see initially actually a rip happened, pigment epithelial detachment. This also highlights the disadvantage of doing focal laser or thermal lasers. It can cause rip of these lesions, but it subsided over. The main advantage is that it gives a longer duration of cure compared to anti-VEGF injection. So it is completely till 2021, no recurrence. It is doing very well. No further injection was required for this patient. Luckily, the rip was not through the center of the macula. This was another 65-year-old lady, totally averse to intravitreal injection. So we did an ICG angiography. You can see the polyps above the disc. This was back in 2016. It was a fundus light-based angiography, and you can see till 22. I recently reviewed her. We treated that lesions by completely by focal laser, and you can use PDT also, but nowadays PDT is not available. PDT would have been a better choice, but actually for some reason she preferred to do a focal laser, and we did a focal laser. You can see the macula is dry. Later in 2017, she developed an ERM, and we did a vitrectomy, and finally in 2022, no intravitreal. She has not required any intravitreal injection. So this is another patient who presented, 75-year-old man, presented with fluid at macula, hard X-rays, and when you do angiography, the macular area is nothing at the macular area, but if you look at the periphery, you see this cluster lesions in the periphery. So this angiography helps us to pick up this peripheral PCV, peripheral exudative chorioretinal vasculopathy as it is called now, and you can treat these lesions with laser with good resolution of edema. And again, when you have large subretinal hemorrhage like this, so you cannot, an OCT may not be able to pick up whether it is due to a neovascular process or due to some other reason. So the neovascular process can be clearly established by doing an ICG. So if you are injecting a C3F8, you can inject anti-VEGF agents also along with it, so that you address both the issues, the subretinal blood as well as the neovascular process. And sometimes, rarely, if you are lucky, you can find what is known as feeder vessels, which you can treat. This was one such lady where we had a type 3 lesion, and you can see the feeder vessel on ICG, which was, since she didn't want injection, this ideally should have been treated by injection, but since she didn't want injection, we had treated it with focal laser with good resolution. We got a 1 year free period. After 1 year, it started recurring again, and we had to do actually intravitreal injection. So these are certain situations where you can, where you have still angiography has a role or an upper edge over OCT. And these are again masquerade. Whenever you have such lesion, this is actually a subretinal, a pre-retinal hemorrhage and hard X-ray. So to a sudden, to a rough examination, this will look like a CNVM. But when you do a angiography, you can see there is this is actually diabetic retinopathy, PDR. You can see that the neovascular process is pre-retinal, and the bleed is also pre-retinal. So this tells you this is a PDR, not the bleed is due to PDR, due to a neovascularization, which is quite posterior, not due to CNVM, AMD. So here again, subretinal hemorrhage, pre-retinal hemorrhage, and a lesion along the retinal arteriole. So angiography clearly picks up the retinal artery macroaneurysm and tells you this is not, you need not inject an anti-VEGF in this case. This is actually a retinal artery macroaneurysm. And here you see an elderly patient with hard X-rays. This is actually an adult onset. The angiography shows multiple aneurysms and telangiectatic vessels in the periphery. So this is an adult onset Coats disease, nothing to do with AMD. So you can treat these lesions with laser alone, and you can. So these are just few examples. We have many examples where we can angiography as an advantage in detecting these mimickers of AMD. So to conclude, FFA and dye-based imaging are essentially in AMD, at least neovascular AMD, and helps us to understand the disease process better. And it also gives us a baseline documentation that what is the extent of lesion, and you can pick up peripheral lesions, you can identify mimickers, and you can look for alternative treatment options in resistant cases. Thank you all.
Thank you, Prakash, for highlighting this role of imaging modality. But as you said in the beginning itself, OCT seems to have hijacked this, at least the dye-based imaging. If non-invasive imaging in the form of FAF and Octa, people may still be doing, but FA role, fortunately or unfortunately or whatever, a lot of retina people keep still doing it, and but the numbers have come down. Numbers have definitely come down. But I was very much impressed by the volume of your photographs which you showed, and some take-home messages I think for people would be that you see, whenever there is a large hemorrhage in the posterior pole, subretinal hemorrhage which is below the vessels, I normally go ahead and do ICG, because to rule out PCV, which may be a finite treatment, although we don't have a PDT now, but at least some extra foveal can be picked up, like you showed one very nice photograph. They responded to your focal laser treatment. And also rule out some Mescard syndrome, like you showed a lot of examples of hemorrhage there, which were either because of macronism or complications of PDR or coarse disease. The other thing fascinated is about the peripheral PCV. So that again is a underdiagnosed kind of entity, because that you can't pick up on OCT unless even if you have wide field OCT. I think still imaging or FA does play a role in picking up those lesions, and that is a treatable thing, because if you ablate that areas, it's a finite treatment, and a lot of people keep giving injections. Because if you ablate those areas, that in such scenario, I think this imaging has a great role to play. So any other point, Gopal, you would like to make?
Traditionally, fluorescent angiography and indocyanine green angiography gave us the physiology of the lesion, and the anatomy of the lesion would be captured by an optical coherence tomography. But the OCT angiography actually gives us an indirect evidence into what is happening. Like Prakash was telling, how this lesion happened, this can be picked up a lot of times by the fluorescent and the ICG. Autofluorescence definitely has a role. Yeah. One important role is that you need to document the changes, what is happening, and show it to the patient. It is patient education, his perception of his own disease. For that, you require to document. OCT definitely shows that, but if you have a frontal picture of this thing, it will be definitely beneficial. What has happened with the injections is that whatever the lesion you are injecting, that is the message which has come out. So that is why the role of fluorescence is slowly reducing. Yeah.
See, I agree. I also agree with Prakash that I am not very confident of diagnosing RAP lesion on any other modality except invasive imaging. RAP lesion somehow, although clinically you may see, but people say on Octa you can diagnose or other. As of now, I'm not very confident, but you showed wonderful pictures of RAP, which were managed by laser also and by injections also. But there is definitely a role of. But I agree, FAF I think is the single most specifically for dry AMD, and also for monitoring the progress. And like you said, reticular kinetosine or which have increased chance of developing into neovascular ARMD. So that definitely is. And FA and ICG also have a role, because specifically in people who are not responding, you see that is people who are not responding to conventional anti-VEGF management, that we should take recourse to ICG and FAF. And specifically if there's a large hemorrhage, large posterior pole hemorrhage subretinal, then I think ICG is of paramount importance, because it will beautifully bring out the polyp in a lot of these patients, so that you can do a combo kind of treatment. You do a pneumatic displacement also, You give anti-VEGF also, and along with PPA sometimes you can do. If it polyp happens to be extrafoveal, then laser can put an end to all such treatments. So Prakash, anything you want to tell about based on your talk about take-home messages for public?
Yeah, that's all, sir. That you should always consider angiography. You should not forget angiography. You should always consider, even though you are mostly doing OCT, once a while in these difficult cases or mimickers, when you suspect, you should always think of angiography as an option.
One important question is, should we do the indocyanine angiography initially itself with the rather higher percentage of PCV in Indian and Asian population? Or should we do
this was a thought process a couple of years back. From 5-8 years back, I used to fight with Novartis that why don't we install ICG in a couple of places so that we can refer. But as of now, with anti-VEGFs reigning everywhere, it is the non-response definitely. But ICG in all patients of suspected AMD or suspected this thing. I know Asian population has around 25 to 33% of PCV. But if there is a clinical suspicion, yes. Clinical suspicion means massive exudation, massive hemorrhage, posterior pole, or non-response. These are the patients, because remember, it's a expensive investigation. It's not a, plus apart from being invasive, it's an expensive investigation.
The only caveat here is that, if you have an extramacular polyp, you could probably treat it with a laser and not continue the injections.
That is, I agree with you. If it's extra, you see, because with non-availability of PDT, we are hoping, because extramacular polyp is one thing which, can put an end to injections, or injection may not be required. So that indication, I agree, definitely.
So should we move on?
Yeah, Prakash, thanks a lot for showing wonderful images, truly wonderful images.
Thank you, sir.
Now, what is most important in AMD in its activity determination is the fluid. And before we go into OCT and OCT angiography and its biomarkers, we will have Dr. Vasumati Vedantam, who is the senior consultant retina at Chennai. She's in Radri Netralaya. She's the director there. And she will speak to us on the relevance of fluid in AMD and what the fluid means to us, intraretinal, subretinal, and sub-RPE. Over to Dr. Vasumati.
Hey, Vasumati, how are you? How are you, Vasumati?
I'm good, Dr. Lalit Verma. Happy New Year to all of you. And thank you, Dr. Gopal and the team at AMRITA for the kind invitation. Thank you, Dr. Lalit Verma. With your permission, I'd like to share my slides. Is my slide visible?
Yes, you can make it full screen.
I'll just go on to slideshow. Please do tell me if it's visible.
Yes, it is visible. Yeah, it's visible full screen. Everything is good. Okay. Let's go ahead.
Good morning to you all. Basically, I'm happy that we are part of this CME on neovascular AMD. And as you're all aware, neovascular AMD is a heterogeneous disease with a variable natural history, and different patients respond differently because of variable degree of VEGF suppression, variable response to anti-VEGF agents, and also there is a variable interplay between activity as well as atrophy. So we really do not know which is the true marker of activity and which is a true marker of atrophy, and where we stand now. And fluid, as Gopal mentioned, is one of the most important OCT biomarkers as well as the prognostic markers in neovascular AMD. And a lot of studies have emerged recently regarding the application of fluid and its interpretation vis-a-vis the management of AMD. And in this talk, I just hope to make justice to this topic. It's a much maligned topic, much discussed topic. So let me just throw light on it based on scientific evidence. And we really do need to understand, are we putting too much importance on fluid, and is drier retina really a better retina? So this fundus photograph as well as the OCT definitely demonstrates the CMVM and the fluid at all levels of the retina, the sub-RPE, subretinal, and the intraretinal fluid. So obviously, it's a no-brainer that this patient is going to have poor vision. And following anti-VEGF injection, so this patient, the fluid has almost totally dried up. With the CMVM lesion, is still scarred, but still very much present. So the visual acuity of this patient has definitely improved when compared to the previous picture. So this is a no-brainer, definitely. And this clearly shows that, and clinicians have rightly employed fluid as a prognostic tool for so many years now. And the imaging, though fluorescent angiography has got its own role, ICG has got its own role in the investigations of neovascular AMD, there is reliance more and more on OCT as well as OCT angiography in recent days. And that is why the emergence of fluid as an important prognostic biomarker. And it's a very easy way to monitor the improvement of the patients in terms of vision, as well as the functional visual outcome, as well as to prognosticate to the patient and reassure the patient as well as ourselves that things are going in the right way. So if we talk about neovascular AMD, it's a chronic condition. The fluid accumulation is a major concern in neovascular AMD progression. So this is basically the CMVM is there all throughout. This is the non-exudative type of neovascular AMD, which is usually picked up by Opta and not even OCT, in which the retinal architecture is more or less intact and there is no fluid. All the havoc, the clinical symptoms of the patient as well as the sign happens with this CMVM actually starts to secrete fluid. That's why fluid is so important. We have the subretinal fluid and then the distortion of the inner retinal architecture, which leads to the symptoms in the patient. And this is the subretinal pigmentoepithelial fluid. This is the subretinal fluid. You can see the accumulation of the fluid in the retinal layers, the photoreceptors getting displaced. And this is all the intraretinal fluid. And with chronicity, we have intraretinal cyst formation. So, and that is the rationale for the use of anti-VEGF agents, because not only do they inhibit the formation of new blood vessels, but also they stabilize the retinal morphology and remove the fluid. And that is why anti-VEGFs have revolutionized the treatment of neovascular AMD. So I will be talking about my topic in 3 subtopics. First is the presence of fluid itself. What is the relevance in AMD? Right from CAT, which is the mother of all neovascular AMD trials, fluid is definitely a very important component of neovascular AMD disease activity period. So CAT study showed that at baseline, 82% of study eyes had fluid involving the foveal center, so the subretinal fluid as seen by OCT. 30% of patients had fluid in all compartments. So subretinal fluid was the most common in 82%, 75% had intraretinal fluid, and 50% had sub-RPE fluid. The clinical relevance of fluid, retinal fluid in AMD, there are several studies, so this is just a slide collating everything. With fluid, we can talk about the treatment interval, and we can plan the treatment interval and devise durable therapies to control fluid. And several studies have shown that this is what could optimize the visual outcomes and reduce the treatment burden and treatment fatigue to the patient as well as the clinician. And again, for diagnosis, the presence of intraretinal and subretinal fluid on the OCT scan are one of the leading diagnostic criteria of neovascular AMD. This has been adopted by several studies and several organizations. And also the visual outcomes. Many studies are there which clearly show that when we rapidly treat neovascular AMD initially and aggressively and reduce the fluid, the final visual outcome is definitely optimized. And also the time to first treatment. Treatment-naive patients, patients who present initially itself after the onset of symptoms, the visual outcomes are much better with a shorter time also to rehabilitation. So current best clinical practice basically states that fluid is an indication of active disease, mandating further anti-VEGF therapy. So that slide was just a collation of all the scientific evidence. And across all the neovascular AMD landmark clinical trials, be it CAT, Ivan, Gefal, Harbor, Lucas, View, name it, the fluid has been a key retreatment criteria. Any fresh subretinal fluid, increasing intraretinal fluid, any fluid on OCT, so many studies of different criteria, but basically any fresh or increasing fluid means the disease is active and needs to be treated. And in case the treatment has been stopped, the treatment needs to be reinstituted. Coming to my next subtopic, what about the subtypes of the fluid? What is the relevance in AMD? All retinal fluid is considered pathological. There's no doubt about it. We have definitely 3 compartments of retinal fluid when we talk about neovascular AMD: sub-RPE, subretinal, and intraretinal. And usually it is the sub-RPE fluid which starts first. and then it becomes the subretinal, and then it becomes the intraretinal fluid, unless we are talking about a type 3 CNV in which the reverse occurs. And these are the examples of intraretinal fluid, be it intraretinal cyst, intraretinal edema, macular edema, retinal edema, exudates, hemorrhage. Subretinal fluid could be serous retinal detachment, hemorrhagic retinal detachment, subretinal exudates. Sub-RPE fluid could be sub-RPE hemorrhage, a pigmentoepithelial detachment, serous and hemorrhagic pigmentoepithelial detachment. All these are the different examples of intraretinal, subretinal, and sub-RPE fluid. Now, coming to intraretinal fluid, what is the importance of intraretinal fluid? It can accumulate in well-defined spaces, which are termed as intraretinal cysts or IRCs. And several studies again have shown that the presence of intraretinal fluid or intraretinal cysts at baseline, when the patient actually presents to us, if the patients have a lot of intraretinal cysts or intraretinal fluid, that has a negative impact on the best corrected visual acuity, both initial and final. And both residual intraretinal fluid or resistant intraretinal fluid, which doesn't go away with treatment, are associated with worse final visual acuity outcomes. So these are all, again, a collation of several studies. If we talk about the importance of subretinal fluid in patients, this is a slightly gray area. We really have not understood how exactly to keep or treat subretinal fluid in the context of relevance of fluid subtypes in neovascular AMD. In some studies, presence of SRF at baseline as well as residual SRF are associated with either better or visual outcomes. There are some studies that have mentioned that it's better to keep the retina as dry as possible, but those studies are a minority. The majority of studies, however, say that too much of SRF is bad, and if SRF is controlled well, it's good. And leaving behind a little bit of residual SRF has a probable protective role against the development of retinal atrophy. However, we don't have robust clinical evidence and a study which clearly tells us in black and white. Coming to sub-RPE fluid, that is a very very less understood concept, the importance of sub-RPE fluid vis-a-vis AMD. And only a small number of studies have actually looked at it and the importance of sub-RPE fluid in neovascular AMD progression, probably because the sub-RPE fluid is the most difficult of all the fluids to be completely removed from the eye. However, changes in the sub-RPE space need to be monitored carefully. They could be an indicator of active or retinal disease. Now, to summarize, why are fluid compartments relevant in neovascular AMD? Intraretinal fluid is typically associated with worse visual acuity at baseline at any time point than subretinal fluid or sub-RPE fluid. So if there is a quiz question for postgraduates saying which subtype of fluid is the most dangerous, it's definitely intraretinal fluid. Subretinal fluid typically associated with better visual acuity at baseline as well as over time when compared to intraretinal fluid. And even if it is little residual, it's not associated with severely adverse visual acuity results. So while making treatment decisions, we do not know all these questions of how much fluid to leave and how much fluid not to leave. When you talk about subretinal fluid in isolation, it's not so clinically relevant. We should take it as a whole, take the patient as a whole, take the OCT, Opta, and the clinical, the visual acuity and the pictures together and make decisions rather than just see subretinal fluid alone. And sub-RPE fluid, of course, if correlated with intraretinal fluid or subretinal fluid, is linked to poor visual acuity. This is just a cartoon which shows what I have been telling you. Sub-RPE fluid, the role is not yet very well elucidated. But sub-RPE fluid, if there is IRF and SRF, it needs to be taken seriously. But sub-RPE fluid alone, we might, just keep a close watch and not choose to jump onto treatment. And the current EURETINA, the Royal College of Ophthalmologists and American Academy of Ophthalmology, all have mentioned that OCT should be used, and retreatment is basically mostly fluid driven. So whenever there's a fluid or hemorrhage, and that's one of the most important indications of retreatment. In fact, in the RCO guidelines, if you see, that is the first point, even before the visual deterioration. So coming to my last subtopic in this, tolerance of fluid. So we talked about the relevance of fluid. We all know that it's now a very relevant topic. We know the subtypes of fluid, what is the relevance, and now how much do we tolerate? Because many times, in fact, we are faced with resistant cases. So how much of fluid can we really tolerate? See, there is one, all of us have OCTs in our practice. Optas are also becoming an important tool in our armamentarium. But all these studies so far and all our clinical experience so far is based on OCT. So fluid is the most important biomarker in OCT when it comes to neovascular AMD. So since most of our experience is not driven by Opta, we really cannot talk about any other prognostic marker, like for example, the morphological type of CMVM. We don't have robust studies which talk about that still. So since we are basically only concerned about OCT and fluid, most of the studies have suggested that fluid may not be a very robust anatomic marker of neovascular AMD, because if we just treat based on the presence or absence of fluid in the OCT blindly a patient, then the final visual outcome throws some surprising results. I will show you some big randomized controlled studies, post hoc analysis, which will suggest that there is definitely a disconnect between the visual and the anatomic outcomes in patients receiving anti-VEGF therapy. Our goal is, of course, we have to strike a balance. We have to strike a balance. We need a maximum visual outcome, at the same time minimize the treatment burden for patients. So we need to walk very carefully. To make you understand what exactly I'm telling you about, these are the Hawk and the Harrier post hoc analysis. Hawk and the Harrier told these analyses clearly show this is the early fluid-free interval and this is the not early fluid-free cohort of patients. And over a period of 2 years, definitely patients achieving early fluid-free status in the treatment have better visual outcomes. So when they reach earlier fluid-free status, the visual acuity becomes definitely better and stays better. This is the post hoc analysis. And of course, patients have to adhere for a longer duration treatment regimen. So this was a post hoc analysis of Hack and Harrier. But what is a view post hoc analysis which compared the aflibercept and ranibizumab had to say? This is the absent fluid cohort at week 12. This is the then this is the fluid which is present at week 12. And if you see, this is ranibizumab and this is aflibercept, and this is at week 52. You see that there is not much of difference. The visual outcomes at week 52 were actually independent of the visual fluid status, which was observed at week 12. And again, this is a view post hoc analysis. If you see the mean best corrected visual acuity by the fluid state at 1 year, regardless of whether it's dry or wet, there was no significant difference in the final visual acuity. And again, view post hoc analysis, this clearly shows, both these slides clearly show that this is persistent dry and not persistent dry. There is a disconnect between anatomic and functional visual outcomes. So just because a patient was very dry doesn't mean they go on to have, throughout the study, doesn't mean they go on to have a final better visual acuity than patients who remained relatively wet throughout the study. So it may not be appropriate to have a fluid, consider fluid by blindly and plan all our treatment protocols just based on fluid. And this is again yet another busy slide, but this is the visual functional visual questionnaire score, and that also shows that there is not much of difference, in patients who were very dry throughout the study and early dry also when compared to patients who were wet intermittently during the study. So even the quality of vision wise, that also there was no great difference. And despite greater resolution, compared aflibercept and ranibizumab, and this post hoc analysis also shows that despite a greater resolution of subretinal fluid with aflibercept than with monthly ranibizumab, finally, if we see at week 52, there was no actual difference in the visual acuity. And then it also, the view sub-hoc, post-hoc analysis, when we analyze about intraretinal fluid and subretinal fluid, does that make any difference? So there is further evidence that patients with the residual intraretinal fluid, of course, have poorer vision than those without, whereas patients with residual foveal subretinal fluid have better vision. This is again the same thing. This is the overall intraretinal fluid, and this is the overall retinal fluid, intraretinal fluid, and subretinal fluid. So IRF is the dangerous one. So we need to really plan our treatment protocols to completely dry the retina in terms of IRF. SRF is okay. Little bit of SRF is persistent. Still, actually, patients turn up with a better visual acuity, especially towards the end. seen in the Caucasian populations, probably because they have a greater predilection of atrophy. And there are several studies, including Harbour, which point that, leaving a little bit of subretinal fluid may have a protective role against the development of retinal atrophy. So that is why probably a little bit of SRF, actually patients did better towards the end. So this is again the slide which shows that the intraretinal fluid is the bad one. The CAT trial post hoc results also clearly show that any eyes with intraretinal fluid had markedly worse visual acuity at all time points, whereas SRF was not bad at all. So this is post hoc analysis from CAT trial. So priority should be based on resolution of intraretinal fluid, and zero tolerance approach to subretinal fluid may not be required to optimize the outcomes of neovascular AMD. Coming to the much maligned fluid study, it's a very ill understood study. It just said when you tolerate fluid of less than 200 micrometers, it never said stop treatment. The study clearly said you could just extend the treatment intervals without compromise on the final visual acuity. And I think it's a very sensible study. And though it has not been understood very clearly. So the study clearly showed that even when you aggressively chase SRF, it's not actually associated with a great functional benefit, vision benefit to the patient. It just leads to an unnecessary increase in the number of injections. The study also showed that patients who had a less aggressive approach in the relaxed arm of the study definitely had much greater treatment intervals when compared to patients in the intensive arm, and they all did better than the patients with intensive arm. This is the post hoc analysis of Harbour, a very beautiful study in which that also clearly showed that IRF was the villain, whereas SRF could be easily tolerated. An Altair post hoc study again talked about the IRF being the bad one, SRF the better one. So did the ARIES post hoc studies. So this is again the Hawk and the Harrier, which clearly showed that brolucizumab had a greater drying efficacy. But when you see towards the end, though the post hoc analysis did suggest that patients who achieved the early drying had better visual acuity, finally, when you see the overall visual acuity, when you compare the drying as well as the final visual acuity, the difference in the retinal drying did not actually be associated with any functional benefit to the patients. So to summarize, I agree that it's a relatively a gray area, but there are several important points. Fluid, as we stand today, considering that most of our treatment decisions are OCT driven and not OCTA driven, is an important prognostic biomarker of neovascular AMD. And current best clinical practice states that any fluid or fresh fluid, especially when the patient presents to you or during the course of treatment, when you have temporarily stopped treatment, re-emergence of fluid, we have to take it seriously. Just sub-RPE fluid, we can observe. Aggressively remove the intraretinal fluid, which is the bad one. Little bit of subretinal fluid, we may tolerate, especially if it is resistant. And it may be a protective factor against retinal disease, atrophy. Thank you so much for your patient hearing, and looking forward to a wonderful discussion and a wonderful CME.
Thank you, Vasumati, for igniting this debate early on Sunday morning, because fluid debate and fluid, has been going on, pushed by ILIA people and pushed by other companies also. So there is a lot of push by the pharma companies where we borrow all these slides from those companies and project. So my take on this is God gave us dry retina. Okay. And I believe all fluid is bad. Just because we can't eradicate fluid, and we say because it is not only the incompetence of the available anti-VEGF, they're not able to dry. People say, okay, thoda bahut SRF is tolerable. And people are going on to say as if SRF may have protective role. You see, you only said there's no robust level 1 evidence to say that presence of SRF, should have a protective role on the development of geographic atrophy. But I agree. You see, like you said, the best biomarker is fluid. And within those 3 compartments which you elucidated, these are the messages I think which should go for general public. IRF, SRF, and sub-RP fluid. The zero tolerance should be for IRF, because that is where you used very good adjectives once you were saying that IRF is the villain, IRF has zero toleration, and we have to chase this very appropriately. whereas reverse may be true for SRF. Although we all try, you see, we all try to chase SRF also, but if it does not, we don't, keep chasing it till it becomes dry. So, but another slide which you showed, all these patients who have persistent SRF require monitoring. You can't say SRF hai, okay, you can go and come after months and months. So SRF, but there are a lot of other agents which are coming up. You see brolucimab, which have marked drying effect on SRF also. Marked drying effect. You see, I have treated around 23 of these eyes with SRF and sub-RP fluid, all went away. So what I do in my practice is, so we do with conventional anti-VEGF agents. If patient is doing pretty well from IRF point of view, well and good. But if not, and there is a persistence, we do offer this newer kid on the block about, because if this achieves drying, if time permits, I'll show you a couple of photographs where there's a dramatic drying of SRF and dramatic flattening of RPED and sub-RP fluid, gone, absolute normalization of control. So we should, you see, before a patient comes to us with Google knowledge and all these things, in our clinical practice, we should. But I agree with a lot of your observations. The message, what should go is, fluid is the best biomarker for AMD. And with regards to subtypes of fluid, it is the IRF where we have to have zero tolerance. And SRF, it does not go, don't be too panicky about it. And you can have patients tolerating SRF with reasonably good, visual acuity. But I don't know today with how much of conviction I can say you can leave SRF for eternity. But these patients have to be under follow-up also. Yes, Gopal?
Vasumati, emphatic as ever, really wonderful talk. So I want to say that, we have all been treating patients, AMD patients with injections over the last 10, 15 years. So if there is nothing to beat monthly injections for life, there's nothing to beat that in terms of efficacy. So our question is how to reduce that burden to the patient, how to treat and extend, how to make it into PRN, and how to use our modality so that the number of injections can actually reduce. So when that happens, let me also tell you that the presence of fluid does not cause a lot of, maybe it will cause a slight reduction of symptom, maybe one line reduction, or maybe a little bit of increase of metamorphopsia to the patient. That is not what we are treating. What we are treating is, if you leave intraretinal fluid for a little longer time, or maybe in the other compartments also for a little longer time, it will immediately cause bleeding and complete loss of vision. And that is what we want to prevent, number one. So it is not about the slight increase in fluid and slight decrease of vision that you are continuously treating, like in diabetic macular edema, but here we want to prevent a bleed. And the number two is scarring. So I have, if I have one patient who is religiously following up with me and getting an injection as and when necessary, whenever you are telling, versus another patient who is coming off and on and getting a treatment, the possibility of him moving into a bleed and also to a subsequent scar is much earlier. The persons who have been following up significantly, very, very, very rigorously with injection whenever necessary, when there is an increase of fluid, the scarring, the geographic atrophy, all those things came in maybe 5 to 7 years, 8 years, 9 years later. Whereas the people who do not follow up and get accumulated fluid over a period of time rapidly go into scarring. That is the basic thing. Thank you, sir.
But I think what Vasumati has said is very, very loud and clear. For we will not go into much controversies in this because it is meant for general public and ophthalmologists, that fluid is the best biomarker and IRF zero tolerance is the villain and you have to chase it aggressively. These three adjectives I copied from your talk, and these I think should percolate down the masses. That zero tolerance for IRF. I think with this, Gopal, any other point anybody wants to add? I think we should move on.
Yeah, I think we should move on to Dr. Natasha.
Natasha,
Natasha is my colleague at AMRITA Institute of Medical Sciences, professor of ophthalmology and retinal surgery. So she will talk to us about OCT biomarkers in AMD before Neha comes in with angiography, OCT angiography.
Wonderful talk, Vasumati, and excellent slide.
So much, Dr. Lalit.
With a lot of conviction, with very, very bold statements you have made. Very nice.
Thank you.
Yes, Natasha. Yes, Natasha.
Good morning.
Hello,
all.
Natasha.
Happy New Year to you. Happy New Year to you, Dr. Basumati.
Hello, Neha.
Hello, Dr. Neha. So I will go on to my slides.
Yeah, we can see the slide. You can maximize it.
So we've all heard Dr. Basumati on how to treat and when to treat the wet AMD. What we are now going to look at are a few subtle OCT biomarkers in AMD. What are we going to look for? Is there any way we can prognosticate AMD when the patient comes to us? So recently there has been a lot of interest in this topic in various areas, not only in AMD, in diabetic macular edema, vein occlusions, and also in the area of wet age-related macular degeneration. The use of OCT biomarkers as a non-invasive predictor of good or bad visual outcome following treatment. So we are trying to find out if on baseline imaging characteristics on OCT, is there any way that we can say that this patient will respond very well to our anti-VEGF treatment and this patient will not? The evolution of the higher definition OCT devices and refined equipment now have given us more accurate assessment of the retinal layers, the abnormal deposits, and the surrogate OCT biomarkers, and this has aided us in this in the efficacy of our treatments. So, like we have seen in Dr. Prakash's talk that like historically we have always classified it using the FFA into the classic CNVMs and the occult CNVMs, but OCT brought in an entire new dimension. So this picture is very familiar to all of us, but I just want to highlight the layers that you need to look into when we are looking at OCT biomarkers, which is mainly the ellipsoid zone. You can see that line just above the retinal pigment epithelium, and the RPE-Bruch's membrane complex. In the normal OCT, we have hyperreflective bands, hyporeflective bands. I will not go into the details, but abnormal reflectivity, reduced reflectivity usually means there is fluid, which we talked about already, the intraretinal fluid, the subretinal fluid, and the sub-RPE fluid. And increased reflectivity is suggestive of hard exudates, fibrosis, epiretinal membranes, choroidal neovascular complex, RPE hyperplasia, RPE atrophy. Now, what are the OCT biomarkers that have been studied? The central foveal thickness, intraretinal fluid, intraretinal cysts, hyperreflective foci, ellipsoid zone integrity, subretinal fluid, and pigment epithelial detachment. Of this, the central foveal thickness and intraretinal fluid we have already dealt with in great detail. They are markers of activity and they require treatment. The central foveal thickness is measured from the ILM at the fovea to the Bruch's membrane with the help of an inbuilt caliper tool in the software of the SDOCT machine. The intraretinal fluid is identified as optically empty area confined to the inner retina on SDOCT. The intraretinal cysts, these are further classified into degenerative and exudative. Degenerative cysts can have any of these two characteristics. RPE layer that underlies the cystic area should be altered, either atrophic or scarred. Squared lesion having at least one concave border or a straight border. And a small IRC is a cyst measuring less than 125 microns without any alteration of the adjacent retinal layers. These are all characterized as degenerative cysts. However, the exudative cysts are very large and they alter the anatomical layers of the retina. So this is a small degenerative cyst. Subretinal fluid, of course, is the optically empty area that lies directly internal to the RPE-Bruch's membrane complex, external to the outer retina. What are high reflective foci? So these are small hyperreflective particles that are scattered throughout the retinal layers and are formed due to accumulation of proteinaceous materials or activated microglial cells. They are further divided into type 1, type 2 and type 3, of which type 2 and type 3 are more important in macular edema, and the type 1 is what is more important in AMD. So type 1, they are less than 30 microns in diameter. They are located in inner or outer retina. There is absence of back shadowing and the reflectivity will be similar to the retinal nerve fiber layer. Pigment epithelial detachment, we know, is an inward deviation of the normal contour of the RPE. The height of the PED is important in terms of OCT biomarker. Serous PED and fibrovascular PEDs can occur in AMD. So this is how we measure the height. However, the OCT machine does not give us a measurement of the height of the PED directly. You have to use the caliper and measure it manually to get the height of the PED. The EZ integrity, it is a second hyperreflective band over the hyperreflective RPE layer, and its intactness or disruption needs to be noted when you're looking at the biomarkers. Here you can see in the first picture it is disrupted, in the second picture it is intact. Now, what are the studies that we have? So what is the evidence that we have for OCT biomarkers? These are the biomarkers consistently in various studies that have shown to be associated with poor baseline visual acuity. So when the patient presents to you, if all this is there, they are likely to have poor baseline visual acuity, which are the intraretinal cysts, the presence of PED, disrupted external limiting membrane, disrupted EZ, greater baseline central foveal thickness are all coordinating with poor baseline visual acuity. Now, poor visual outcomes. PED height of more than 250 microns, presence of degenerative IRC, and presence of disrupted ellipsoid zone are found to be associated with poor visual outcomes after treatment with anti-VEGF agents. Now, degenerative cysts showed poor response, while exudative cysts showed good response to anti-VEGF therapy. Because this is postulated to be because degenerative cysts cause tissue loss that lead to the poor visual outcome. Chronic occult CNVMs that have high protruding PEDs, which have a height more than 250 microns, have poor response rate. The ellipsoid zone, when it is disrupted, it causes loss of functionality and therefore results in poor response to treatment. Good visual outcomes, subretinal fluid, presence of subretinal fluid at baseline is a predictor of good visual outcome. Presence of the hyperreflective foci is a predictor of good visual outcome. Intact ellipsoid zone in the overlying retina is a predictor of a good visual outcome. HRF are said to be the result of early inflammatory reaction and represent activated microglia cells. And if they show good response, so after you inject and you find that the HRF that was there at baseline is now disappearing, that can show that your treatment is going to be very effective and the patient can have good visual outcome. The persistence of the high reflective foci after the initial loading dose was however correlated with poor visual outcomes. Let's see a couple of representative patients. These are patients who have been treated with monthly injections of ranibizumab, and we have just done a small analysis. So in this patient number 1, you can see baseline visual acuity was 618 with a large PED, intraretinal fluid, and there was subretinal fluid, but the EZ in the overlying retina is intact. This patient post-injection improved steadily from 612 to 69 and disappearance of fluid. Post third injection, maintaining good visual acuity at 6.9. The next patient you can see has shallow PED with good SRF, and again the overlying retina is fairly intact, and this patient actually also showed good improvement from 624 to 618 and maintained on 618, and post third injection had 6.9 parts. However, look at this one with a large PED of 625 microns with a disrupted AZ and some absence of SRF. 624, second injection 618, third injection 618, and visual acuity is not improving as much as we wanted to improve. And this is post third injection with the SRF disrupted. This is a patient number 4. This is a patient at day 0, you can see has subretinal fluid but also has a disrupted ellipsoid zone as well as a fibrovascular PED, and later improved only to 612. But what are the limitations of using OCT biomarkers? One of the problem is that most of these studies have been done on bevacizumab and ranibizumab. The newer anti-VEGFs, for example, we all know in our practice aflibercept flattens out the PED much faster than ranibizumab does, and therefore probably this height of the PED may not be so important when you're looking at treatment with aflibercept. So these two newer anti-VEGFs are less studied and regarding biomarkers, and only future studies can give us this data. So in conclusion, we can only say that OCT biomarkers may give us a non-invasive way to predict visual acuity response in CNVM and may help to prognosticate CNVMs. At present, evidence suggests that PED less than 250 microns, PED more than 250 microns, degenerative cysts and disrupted EZ are consistent predictors of poor visual outcomes, while SRF and intact EZ have better visual outcomes. But in the future, with better machines, OCT biomarker guided treatment will probably help in individualized disease management protocols. I thank you all for your patient hearing.
Natasha, thanks for a precise, up to the mark talk.
Thank you.
The one slide where you showed good visual outcome, where you showed SRF, presence of SRF and intact ellipsoid zone and hyperrefractive foci. I think that should be modified. SRF only. You see, SRF along with IRF nahi hona chahiye, because there should be no, only SRF may be good, because only SRF in AMD is not such a common scenario that you get only SRF. So there you can slightly modify and add SRF only or without.
Just SRF, yes.
And I agree with most of your observations that all of these are good. One question was that hyperrefractive foci, which you said are markers of inflammation, hyperrefractive, as anywhere, in diabetic also and here also. So, because all these anti-VEGF agents which we inject are pro-inflammatory. So all these agents, they reduce the permeability or maybe neovascularization. So they are pro-inflammatory. So presence of HRF, if you say, has a good biomarker, is there any role of steroids adding somewhere? Because there has been a lot of debate in this aspect.
That could probably be the reason why, in earlier days, people used to treat CNVM with steroid also with some response. So, but I don't think anyone is brave enough to try it now.
I know some studies being done at LV Prasad by Raja, and I remember a long time back, Augustine used to have a triple kind of therapy, which including steroid along with anti-VEGF and all these things. And although when all these newer anti-VEGF agents came, we had such good responses with them, so we forgot about steroids.
Yes.
So I think the message is loud and clear that SRF alone and presence of, most important I think, is intact ellipsoid zone, because that is the area where the entire vision resides. So that is the area which, if that is intact, so how confidently can you tell the patient where you will have good response? Do you tell this patient to the patient, suppose you have SRF without IRF, and suppose you have intact ellipsoid zone ARMD, and patient is about to receive an injection. So how confidently can you tell, madam, your response will be very good, don't worry about it. You see, studies are something different. How confident are you to tell the patient? This patient has come to you with some expectation, some improvement in vision, because that is the single most important thing which he has brought. Vis-a-vis patients who have PED, high PED, more than 250, or disrupted SRF, then you say, okay, I'm going to try, but I'm not very sure how much will you improve. Do you take these biomarkers in real life scenario and counsel these patients? And what kind of language do you use?
I do, sir. Especially if the patient, when you know there is good, because this is a disease that requires a lot of compliance from the patient. So if you think that the patient is going to improve, I do counsel aggressively that the patient needs to have treatment because he has good visual potential, and probably with good compliance for monthly injections, he will.
No, what I'm going to ask is three markers you have told. Vis-a-vis three markers. One is poor and one is good. So there may be some set of one subset of patient.
Yes, sir. When the ellipsoid zone is disrupted, I do give a guarded prognosis. I do say that, yes, you have at least maintenance, but we also know that maintenance of vision is possible. So I do say that you may not improve a lot, but if we'll at least prevent your visual acuity from going down. So at least to that level, these biomarkers are currently helping us, though we can't accurately predict.
Yeah. Gopal, any other addition you want to make?
Yeah. So the the presenting visual acuity of the patient is a very, very important determinant. And if the patient is presenting with a very slight decrease of vision, maybe up till 612, 618, then all these, OCT-based biomarkers can be easily picked up. But the moment it becomes a little chronic, maybe 2 months, 3 months, especially in this corona times, most of the patients have come to us a little later after the problem has started. And so the scarring has ensued. So in the presence of scarring, definitely the intraretinal fluid, subretinal fluid, all those calculations are not really great. Like many of the patients which actually Natasha showed, with the presence of scarring, the visual acuity won't improve beyond that particular level. And more than the positive counseling that you asked, Natasha, I would say that if there is some absence of ellipsoid zone, which we can clearly delineate on the OCT, or something like that, or the presence of scarring, we can negatively tell the patient that, the visual acuity is not going to improve beyond this. That is also another thing that we can probably say. We cannot.
I agree with Gopal. You see, the ellipsoid zone disruption and, massive disruption, I think you can, what I normally tell these patients is, injection to lagna hi hai, injection to hai, like Natasha is saying. But the degree of improvement I can't quantify. Because the seeing line or where the photoreceptors are there, that is gone because of the disease process. So we will try. How much you improve, time will tell.
Let's move on, sir.
Yeah. Good, Natasha. Excellent talk.
Thank
so Neha is going to tell us about.
So Neha, our good friend and one of the best imagiologists. She thinks intelligently and try to get out the the conclusion out of that. So usually we have 2 eyes to treat. Now here we have Neha, who is founder and director of the TetraView Super Specialty Eye Hospital. So she claims that she will treat 4 eyes. Over to Neha.
Thank you very much, Dr. Gopal, for that special introduction, which you didn't give to anyone else. Good morning, Dr. Lalit, Dr. Natasha, regards to everybody. I thank Dr. Gopal, AMRITA Institute, and the Cochin Ophthalmic Club for organizing this. It's been really a pleasure to listen to all the talks and for giving me this opportunity to put forth my views on Octa in AMD and a little about on fast OCT with regards to Octa as well. I hope my slides are visible and I'm audible.
Yeah. Carry on.
All right. So as we know, Octa is the backbone now for the diagnosis and management of retinal diseases, and OCT angiography is a major leap forward. Rather, it's been called the game changer. Basically, Octa uses non-invasive OCT technology to obtain retinal, choroidal, and optic disc vascular structural information by assessing decorrelation in the OCT signal due to vascular flow. So several algorithms are used. Commonly, we use the OMAC, which takes into consideration both the phase and the amplitude, the SADA, which takes into consideration only the amplitude, or the Doppler, which takes into account only the phase, which is not used clinically. So as a simplification of how OCT works, Octa works, it repeatedly scans a region and examines the resultant image for changes. So the stationary tissue will show no change, whereas moving structures will show changes. So this is basically what we are assessing in Octa. And then there are different algorithms for assessment. So we started with the spectral domain OCT angiography, which employs a broad bandwidth light source coupled with a spectrometer, but now currently mostly use the swept source OCT angiography, which uses an array of photodetectors and a tunable laser light source that sweeps through a range of frequencies. How does this translate into our clinical practice? Now, spectral domain has lower A scans per second, whereas with swept source Octa, these are much faster. And this leads to a greater retinal field of view and a higher resolution because of the increased sampling density. Secondly, the light source. In spectral domain, we know it's 840 nanometers, whereas it's, I'm sorry, there's a typo here. It's longer, 1040 nanometers in swept source octa. So this increased signal penetrates through the RP, through the pigmentary clumps and the drusen, which makes it better for imaging the choriocapillaries. So all the images I'll be sharing will be of swept source OCT angiography. What do we image in octa? As opposed to our conventional OCT, which are B scans, octa usually implies en-face imaging or the C scans, which is a sagittal view as opposed to a cross-sectional view. So basically, we segment and then analyze at various levels, which are most commonly the superficial retinal vasculature pertaining to the inner retina, the deeper retinal vasculature pertaining to the middle retina, and of particular interest in AMD are these three slabs: the outer retina, which normally lacks vasculature, the choroid, which is seen at two levels, the choriocapillaries, and at present you have to manually adjust to see the medium and the larger vessels. The scan size varies from 3x3 to now we have even 12x12 scans. And usually for AMD, I use the 4.5x4.5 scan. The resolution, of course, goes down in larger images. Now, an important concept here is that in addition to the on-face imaging, you must always do and analyze the cross-sectional OCT-B scan with an octa flow overlay. Why is this important? This obviates the dependence on the on-face imaging with the inherent segmentation errors which can happen in a pathologic state of the retina. And this can also be used to evaluate for the potential of projection artifacts, as we'll see later on through the presentation. Now, just to revise, the clinical classification of AMD, which we use, basically divides it into aging changes, early, intermediate, and late AMD. So in early and intermediate AMD, you have drusen with or without AMD pigmentary changes. And these are usually, this accounts for around 90% of the AMD population. In late AMD, you have either neovascular AMD and or geographic atrophy. And though this is less common, but it accounts for up to 90% of the cases of visual loss or visual dysfunction. Now let's start with the utility, clinical utility of octa in dry AMD. So I'll be discussing this under 5 headings. The first is octa in drusen or intermediate AMD. The most striking feature which has been described is the choriocapillaris flow depletion. And there are several hypotheses to explain this finding. It could be a reduced flow velocity below the decorrelation threshold of the octa. It could be an actual choriocapillary vascular depletion under the drusen, or it could be a decrease in the vessel caliber at this level. Now, all of these scenarios would result in hypoxia of the RP and the photoreceptors with consequent metabolic dearrangement. So actually, it is a kind of a chicken and an egg situation because the RP and the choriocapillaries are interrelated in terms of physiology, but octa has shown that probably it is the choriocapillaries which is the primary insult, which leads to the secondary RP dysfunction. So this is the clinical photograph of a patient with the, you can see drusen, the undulations of the RP choriocapillaris layer. And here on the choriocapillaris slab, you see these dark areas, which are the flow voids. Another patient with drusen and drusenoid PED, which is appearing here also on the on-face image. And again, you can see these spots of flow void, which are the choriocapillaris depletion. Secondly, coming to octa in the reticular pseudodrusen, or the newer terminology, which is subretinal drusenoid deposits. Now, as we know, these RPDs are associated with worse visual function and a higher likelihood of progression to late AMD. Now, they significantly affect the photoreceptors, particularly the rods, as opposed to the basal linear deposits, which affect the cones. And they are also associated with a greater reduction in choroidal thickness. So as a corollary on octa, you see a reduced choriocapillaris flow and choriocapillaris vessel density in reticular pseudodrusen as opposed to the regular drusen in dry AMD. And in about 30% of the patients, this flow impairment can even extend beyond the margins of the drusen. Third, coming to octa in geographic atrophy, which is the hallmark of advanced non-exudative AMD. As we know, there's atrophy of the outer nuclear layer, the ELM, the EZ, the photoreceptors, the RP, and finally the choriocapillaris in the setting of these characteristic extracellular deposits, which causes increased transmission of the OCT signal below the basement Brooks membrane, especially visible on the swept source OCT. Now, FFA, ICG, and OCT have limited utility in visualizing the pathological vascular changes occurring at the level of the choriocapillaries. The current classification of geographic atrophy is into crura and aurora or nascent GA. So basically in crura, there is complete RP and outer retinal atrophy, as you can see here, leading to a homogeneous hypertransmission at the level of the Bruch's membrane. In aurora, what happens is there is subsidence of the INL and OPL. You can see ELM breaks and an interrupted RP. So there is an inhomogeneous hypertransmission at the level of the Bruch's membrane. And this classification has been given by the consensus on OCT group headed by Dr. Srinivas Sadda. So obviously, the choriocapillaries are severely depleted in the bed of the atrophy in GA patients, but importantly, flow impairment has also been seen in the junctional zone surrounding the atrophic core. Now, earlier in the talk on FFA, it was talked about how to differentiate GA from late onset Stargardt disease. And in fact, Octa can help you there, because even in late onset Stargardt disease, the choriocapillaries atrophy is just limited to the area of the atrophy. Whereas in AMD associated GA, you will also see a flow impairment in the junctional zone, which doesn't happen in Stargardt's disease. So it has even been hypothesized that this flow impairment at the margins of the GA may predict the direction and rate of growth of the GA. And these flow alterations may precede overlying RP atrophy. It's important to remember that then in these areas of atrophy, the underlying larger choroidal vessels may be displaced upwards and visualized on the en-face. So this is a patient with dry AMD. You can see pseudophakic, and this will fall into the category of crura because there is complete atrophy of the RP in this region and outer retina, leading to a homogeneous hypertransmission at the level of the Bruch's membrane. And what's happening at the octa? See, in these areas, again, this is the en-face for correlation. You can see areas of choriocapillary flow impairment, and in this patch, you can see the medium and the larger choroidal vessels shining through. Now, fourth, in dry AMD, Octa has a role in picking up the non-exudative or the quiescent CNVs. What are these? These are basically type 1 neovascularization, which are detected solely on Octa with no signs of activity, that is subretinal or interretinal fluid, on the B-scan OCT for at least a period of 6 months. And surprisingly, they may be present in up to 25 to 30% of eyes with intermediate AMD. What's the clinical relevance of these patients? While they do not meet the criteria for anti-VEGF therapy, but definitely they require a closer follow-up, and the patient should be educated about his condition. In fact, it has been hypothesized that this condition may be protective for GA progression because there may be a potential nutritive effect of the neovascularization on the RP and the overlying neurosensory retina. So this was an elderly patient with dry AMD, both eyes pseudophakic, and you can see circumscribed areas of geographic atrophy. This was an aurora patient because there is inhomogeneous transmission, you can see, and then still interspersed, you can see the EZ and the RP here. So this is the right eye, this is the autofluorescence, and this is the left eye. The FFA, as I said, in these cases will not show much except for staining. But look at the octa. This is of the right eye, and you see this network of vessels here with some amount of flow on the B scan. This is the left eye. This is the left eye, and this is the right eye of the patient. Again, you can see a network of vessels with some corresponding flow on the OCT B scan. This is the 1 year follow-up of the patient, and you can see that the membrane remains remarkably similar, and it has not been accompanied by any intraretinal or subretinal fluid on the B scan. So this falls into the category of a non-exudative CNVM. Similarly, this is the left eye of the patient. Again, a similar complex which remains stable over a period of a year. A word of caution here, like I said earlier, this might very much look like a network of vessels on the outer retina and the choriocapillaries, but as I had said, you have to correlate it with the B-scan and the angio overlay here. So as you can see, there's no flow here, and this is basically a choroidal vessel shining through because of this area of atrophy. So this is not a non-exudative CNVM, but this is an artifact. Now look at this patient. This was a 60-year-old male who was referred for a routine checkup actually following cataract surgery. And this B-scan showed drusen, drusenoid deposit at with the overlying hyporeflectivity, which may be interpreted as a subretinal fluid. So naturally, we need to check for the presence of neovascularization in this patient. And FFA does not tell much except, a mild staining in this region. Now look at the octa. In this case, the octa is useful because it rules out the presence of neovascularization. You can see there's no hyperreflectance at the level of the outer retina. And this is another utility of octa, to rule out macular neovascularization in what we call these non-vascularized drusen or drusenoid PD, which may be associated with SRF and again do not warrant any anti-VEGF therapy. But all is not rosy, as with all things, and there are a couple of limitations of octa in dry AMD. Though the motion artifacts have come down with the eye tracker, but then there are still segmentation problems. As I said, there are changes in the contour of the RP due to drusen, and this can alter the automated segmentation alterations. So in this case, you can manually choose a slab which is slightly posterior to the correct location of the choriocapillaries. Projection artifacts, which are basically overlying vessels appearing in the deeper retinal layers, may produce false positives or a pseudo flow. And again, the assessment of the choriocapillaries may be limited by shadow artifacts due to the hyperreflective RP or drusen. But this is more with the spectral domain octa and much less with the swept source octa. Distinction between the choriocapillaries atrophy and flow attenuation might be difficult, though this is not much relevant clinically, but when used as a research tool, the VISTA algorithm can be used to circumvent this. And basically, the flow deficit at this stage cannot be used to reliably predict AMD progression, but it is still a research tool. So next, coming to the utility of octa in wet AMD. We've already gone through all these modalities, and still FFA remains the gold standard for CNV detection, classification, and localization, but it is not without disadvantages. We know it is invasive, and more so than invasive, it is the repeated administration of the dye which makes FFA an unsuitable candidate for follow-up of these patients. Of course, dye leakage, hemorrhage, and media opacity can obscure details. And it is not more important, what I feel most importantly, it is not designed for acquiring segmentation of the different layers. ICG angiography can circumvent the disadvantage of imaging the sub-RP structures, but it remains invasive and hence cannot be done frequently. Now, OCT is the backbone, but it still has limitations in identifying the neovascular tissue due to similar reflectivity with drusenoid material and hemorrhage. This is the important disadvantage which can be circumvented by octa, where the CNV can be directly imaged. Now, it has an extremely high specificity, especially for type 2 CNVs. The sensitivity is also good, though it needs to be improved. Now, octa provides more distinct vascular network patterns as opposed to any of these other modalities, and is also less obscured by subretinal hemorrhages. Now, why type 2 are detected better than type 1? This is because of the PED, and especially with PED heights more than 250 microns, you get segmentation artifacts and OCT signal attenuation. Now, octa can also miss the low flow components of neovascularization, such as the polyps and PCV, and we know that the BVN is imaged better with octa than the polyps themselves. Now, the lesion subtypes on octa follow the same classification as OCT, that is the type 1 or the sub-RP or occult. And various patterns have been described, such as the Medusa form. Here you can see a central trunk with vessels in all directions, or the C-form form. This was again an elderly male. Here is the central trunk with progression only in one direction. But honestly, these are just morphological patterns and do not have much of a clinical relevance. Treatment naive CNV has been described as defined into a dense net configuration and a loose net configuration. And it has been seen that if you find a loose net at the first instance when you diagnose the CNV, then it may predict a longer disease duration for this subset of patients. So just to see, this is an image from the original article. This is a loose net, and this is more of a densely packed net. And here, this was one of my patients, where you usually see both of them together. You see a part of the lesion which is loose net and a part which may be dense net. So this can be used as a biomarker on octa to prognosticate to the patient the duration. Then finally, CNVs have also been divided into mature and hypermature. And basically, hypermature are the aging ones where the secondary capillary ramification decreases, and also called the dead tree pattern. So next, coming to the type 2 or the classic or the subretinal CNV, again, these have also been described, the morphological patterns, as the medusa and the glomerulus. So basically, this is the medusa, where you have one area of hypodensity among the network of vessels. And this another type 2 CNV you can see here. And this is the glomerulus, where you have multiple areas of interspersed hypodensity. So the third is the RAP, the type 3 CNVM, and earlier there was talk about diagnosis on this on FFA and ICG. Now it's important that the diagnosis, I feel, can be better made when the patient comes in the early stage, when it is still in stage 1 or stage 2, because in stage 3 it is very difficult to say that it was a RAP lesion. So in stage 1, careful segmentation can reveal an abnormal vessel at the level of the deep capillary plexus and not the outer retina, because as we know, here is the origin of the type 3 CNVs. And as it progresses to stage 2 or sometimes even 3, you can see that the lesion is connected to a corresponding lesion in the choriocapillary. So this is an image from the original article. Here you see the telltale signs of FFA, the hyperfluorescence, and on ICG. And these are the typical OCT features, intraretinal exudation. And here is the vessel, and now this is at the level of the deep capillary plexus and not at the outer retina. And here you can see the connection with the corresponding lesion in the choriocapillaris. To be honest, you should have a high index of suspicion, but then still I would say that Opta has a pretty good chance of picking it up if you're in stage 1 or stage 2. Now, another utility of Opta in CNVs is the quantitative assessment. So there is literally, with OCT B scans, you cannot actually see the lesion in its entirety. And calculation of the extent of the lesion not only allows you to understand its evolution over time, but also to understand and demonstrate the structural response to treatment. So a higher flow index indicates active blood flow within the CNV, and this is associated with larger CNVs, of course, and those with type 2, because then it can be picked up earlier, being subretinal. A reduction in the size, which is the area or the greatest linear dimension, and the vessel density of the CNVs has been noted in studies after treatment with anti-VEGF, again more for type 2 lesions. So it has been hypothesized that type 1 CNV may be more mature, and hence you do not see it as much as with type 2. This is difficult to use clinically because all these studies have used their own algorithms to calculate the conversion of the pixels, basically what we see on the picture, to the millimeter square, which is the area. Now, this is an interesting aspect, which is the biomarkers of activity of active and quiescent CNV on Opta. We still rely on OCT B scans, as we have talked about the intraretinal and the subretinal exudation. But are there any markers on Opta which can tell us whether the lesion is quiescent or active? Now, this I feel is particularly important when there are no signs of exudation on the OCT B scan, and then you can kind of predict on the Opta which neovascular complex is more likely to leak in the future. So 5 features have been described, though I must say before that these do not have predictive value to guide anti-VEGF therapy as of now. But what they can be used is to tweak the follow-up of the patient. So basically the shape of the lesion, if it is lacy, wheel or C-fan shaped, as opposed to these long filamentous linear vessels, what I talked about, the dead tree pattern earlier. So these lesions are active, the A, and these are quiescent. This is the original article which has been described by Koskas. Then, of course, if there is more branching, more anastomosis, it's more likely to be an active lesion. For the quiescent lesions, you will have less of these branching and anastomosis. And look at the peripheries. You will have these interconnecting arcades at the vessel terminal, which again will not be present here, the dead tree configuration. A perilesional halo has also been described as a marker of activity. And this is again a clinical, patient, where then again looking here, you can know there are less anastomosis, less branching, and no halo around the lesion. So this is more likely to be a quiescent CNV as opposed to an active CNV. So finally, coming to Opta in treated CNV. Now, Opta is the only modality as of now which can be used to visualize the neovascular complex during the follow-up of the patient, as it is non-invasive. So basically what we see is a decrease in the fine capillary vessels at the lesion border and a decrease in the anastomosis. The feeder vessel or the central vessel trunk still remains hyperintense. Now, I find this useful to, again, counsel the patients. It is difficult for them to understand and perceive a cross-sectional image of an OCT. But if you see an en-face image on a OCTA, you can explain to the patient that even though the fluid has gone, the neovascular complex is persisting. And this kind of drives through the message that they still need to follow up and may need more injections in the future. And I use this as well. So this was a patient with type 1 CNVM, you can see, and this is the neovascular, high flow neovascular complex. And this is after 4 anti-VEGF injections. You can see how it has organized, it has shrunk, and there is some decrease in the vessel branching as well. So the sign we talked about earlier, that is the perilesional dark halo, which may surround the neovascular complex in its entirety or in parts at the choriocapillaris slab, is actually a flow void region due to the decrease in the choriocapillaris perfusion. Now, this may represent a vascular steal phenomena because of the flow diverted through the neovascular membrane, and it helps understand the pathophysiology, because the focal choroidal hyperperfusion is the one which might have induced the vasogenic cytokine release from the RP, leading to the neovascular membrane in the first place. So here you can see, this is from the original article, the neovascular membrane and the adjacent perilesional halo, which suggests that this membrane is active. And look at this, you can see a difference in the morphology. This is actually due to decreased transmission and not due to the hypoperfusion. So looking at this patient, this was actually post 1 anti-VEGF injection. It was a type 2 CNVM, and here you can clearly see the perilesional halo in the patient. This is the enlarged view. So limitations of OCTA and wet AMD remain the segmentation strategies, because as we said, the retina is diseased, and so you may have to manually tweak the segmentation. And again, the shadow artifact because of the CNV may lead to underdiagnosis of the choriocapillaris alterations underneath. So to summarize, or to give you the take-home messages, how to utilize, or what is the utility of OCTA in dry AMD. So OCTA has shown us that choriocapillaris flow alterations play a dominant role in the pathogenesis. They cannot be used yet to predict AMD progression, but they may be potential therapeutic targets and susceptible or early surrogate markers of progression in dry AMD. OCTA can be used to detect non-exudative macular neovascularization in patients with dry AMD. And while this does not warrant anti-VEGF therapy, but this can be used to make the follow-up of the patient a little more closer. OCTA can also be used to rule out macular neovascularization in non-vascularized drusen or drusenoid PD associated CRF. And this might save these patients from, again, unwarranted anti-VEGF therapy. What about the utility of OCTA in wet AMD? So OCTA has a high specificity for detection of CNV, especially of type 2 CNVM. And I'm sure we'll have a lovely debate after this. But what I do is, in the first go, if there is a CNV or suspicion of one on OCT-B scan, then I go for the OCTA of the patient. And this does obviate the need for the invasive fluorescein angiography in at least a subset of patients. It is only in which there is some doubt about the neovascular complex, or that a mimicker is suspected, such as a polyp has been discussed, where I go in for the more invasive angiographies. So OCTA helps not only in qualitative assessment, that is the type of CNV, but also in the quantitative assessment, that is the area of the CNV, the vessel density, and the greatest linear dimension. Biomarkers of active or quiescent CNV on OCTA are still under research and hopefully should be available with more certainty in the near future. And OCTA can also be used to demonstrate the structural response to treatment, as well as counsel patients to actually show them how the neovascular complex still remains, and which is why they need, maybe even lifelong follow-up. So in vivo imaging by OCT has significantly enhanced our understanding of chorioretinal disorders, including and especially AMD, with respect to their early recognition, pathogenesis, disease progression, and treatment paradigms. SWEP source Octa is eligible as an additional first-line diagnostic instrument in AMD, possibly decreasing the necessity of dye-based fundus angiography in the future. Octa, however, may not provide consistent information to guide treatment when used alone now, independent of other images in the diagnosis and monitoring of neovascular AMD. But the last straw would be, of course, multimodal imaging, and this is capable of overcoming the shortcomings of each diagnostic modality and would be the most helpful in management of patients with AMD. I thank you for your patient hearing. Just stop sharing my screen.
Yeah, wonderful talk, Neha, as usual. A lot of learnings from your talk. Because people who have experiences of Octa, they will vouch for this. But everybody does not have Octa. And Octa is evolving, as you said. You see, quantitative Octa is now coming up in a big way, which can be with the help of various indices which have been said. But as of today, if someone asks you, the last slide of yours was that it may be the first line of in diagnostic in AMD.
So yes, that's what I said, that after the B scan, or rather with the B scan, I always go in for the OCT angio, whether it's dry or wet AMD. And I now proceed to fluorescein angiography only if I have a reason to. And this, I would say, has changed over the last 2-3 years, where I would order an OCT and an angiography, invasive angiography together. Because there is a good subset of patients which do not or may not ever require fluorescein angiography. This, of course, is with autofluorescence, as has been discussed earlier.
Yeah. No, I agree with this, that Octa has has minimized the role of invasive fluorescein angio. There's no doubt about it. One topic which you had raised was this non-exudative CNVM, quiescent CNVM, which we diagnose in patients of dry AMD. You see, I have seen a couple of these patients. The problem is, you said close follow-up. Most of us don't treat these. But what about in case it happens to be a fellow eye of a scarred CNVM? Then is your approach more aggressive, or you still want to wait and watch?
So like I said, and what this literature also says, that unless there is associated exudation on the B scan, there is no indication to treat them. And another point which I had mentioned also was that, in fact, these may be protective for the progression of geographic atrophy, because a part of the nutrition might come through these complexes and decrease your progression of neovascular AMD. But like the scenario in which you said, I would then look for markers of activity on Octa itself, the 5 markers which I had mentioned. And I haven't come across this, but possibly if there is a change over follow-up and it is progressing from a quiescent to an active lesion on Octa, still there is no fluid on B scan, I might maybe consider or discuss the possibility of anti-VEGF therapy. But that would be a very small subset of patients, I believe.
Yeah. But the reason I asked this was, what are we waiting for? You see, a fellow eye lost because of scarring.
Yes.
This eye, God has given you information that there is a neovascularization there, and you trust Octa so much that this neovascularization is there. But what are you waiting for it to bleed, or for it to?
No, sir. Like I said, it might actually be protective for the GA. We don't know. It might be protective because a part of the flow of the neovascular membrane might be this has been documented, might actually be diverted to the RP and choriocapillaries and delay some of the progression of atrophy. So in fact, we might possibly accelerate the atrophy by injecting anti-VEGF. It's not because you don't trust.
I think this is a conjecture which we are laying a lot of importance to. A couple of published reports that CNVM may be protective for the development of geographic atrophy.
In these patients, when there is no exudation.
I think, Lalit, there are 2 aspects to this. And see, if it's an asymptomatic patient, and this is an incidental finding, then you want to be more cautious because you have to balance the risk-benefit ratio.
My question was fellow eye.
I'm coming to that. This is the fellow eye. The other eye is gone. As an incidental finding, you find a non-exudative neovasculopathy. I would watch the patient for symptoms. If the patient becomes symptomatic, if he starts giving symptoms of metamorphopsia, I will consider treating this patient. And I have 1 or 2 patients like this.
Yeah, I agree. That is 100% true.
Yeah,
that is
but if the patient is asymptomatic,
there's no rocket science in this.
Yes.
The patient becoming symptomatic is everybody will treat.
But even if it is, I'm differing from Neha to that extent, even if it is non-exudative, but the patient becomes symptomatic, it is an indication for treatment. But if the patient is asymptomatic,
unfortunately, patient may not come so fast. You see, the problem with our this thing is patient may not come with metamorphopsia.
Yeah, we are talking about the rare patient who does come. You see, this is not a common situation. But when this happens, this is what the protocol can be. If the patient is asymptomatic, he needs to be kept under a close follow-up and you monitor the neovascular net. If the neovascular net shows changes and increase, that's another indication for considering treatment.
If it is my eye, Neha, I would like to get treated because I don't want to roam around with neovascular network under the RPE. Unnecessarily fellow eye already chale gayi hai, and this I'm not waiting for AMRITA to offer.
I agree, sir. It's an individualized decision where you have to discuss with the patient. Metamorphopsia sometimes, sir, in patients with 6/60 vision and central atrophy is difficult to explain to them or even to come up with it. Many of them, so it can be discussed with the patient. If and like sir said, if it is, we can involve the patient in the decision-making process. Very frankly.
The other very good point,
the patient's philosophy should be respected, and I don't think the doctor's philosophy should be imposed on the patient's head.
Yeah,
in this particular
agreed. I agree because patient to majority of the decision making in this country is left on the doctor. Doctor साहब आप बताओ.
Yeah.
Patient, we don't want to impose, but वो कहेगा patient doctor साहब आपको ये recent CNVM मिला है. आप बताओ इसको treat करना कि नहीं करना. That's what patients, most of the patients of my patients will ask, what is your this thing? If I ask him, नहीं अभी follow up करेंगे, and you come SOS, then so you have metamorphopsia, or when this thing is because we follow too much of whatever is published short case reports rather than evolving our own this thing. Because this thing was, I have one patient who actually lost a big scar in the right eye, left eye, accidentally picked up Cochin CNV. So I treated. I don't want him to, go. You see, possibility of protective
CNVM reduced on OCTA.
Yeah, document. Yeah, and this is the best response. You see, all these myopic CNVMs and all. There's other category. We are not talking about myopic CNVM in this webinar. So those are the other things where I heavily rely on Opta.
So I think as Dr. DT said, the second point, so possibly I would observe for at least a month or 2, even if it is a one-eyed patient. And if, like sir said, there is change in the morphology, you see the perilesional halo, the branching anastomosis, you can make out that this is likely to progress, then maybe take a better decision.
Yeah, that's a good point. I think that is a good vertical follow-up over 1 to 2 months. If there is any change occurring in that, then you are more
and it's not a routine follow-up. You can ask the patient, I want a 2-weekly follow-up as opposed to a 4-weekly follow-up.
Yeah. That I agree.
If the patient, if you are more unsure than that, you can even call for a weekly follow-up. The point is, if you give an injection, now let's keep this in mind. Look at this reverse scenario. You give the injection and he gets endophthalmitis. Tomorrow, you're going to curse yourself that you've given an injection for a patient who had nothing. So you have to balance the risk and benefits. So when I am reasonably sure that I'm dealing with a progressive disease, I will give the treatment. If I am very doubtful, and remember, when these patients have a little bit of geographic atrophy, this is also a cause for an artifact.
Yes, I showed that. Just after the non-exudative.
So unless you're following up sequentially, you won't be able to pick that difference. So that is why it's important.
So final take on this is, follow them up for a couple of close follow-up for a couple of weeks or months. If there is change, then definitely treat such. At least advise this patient. I don't get scared by occurrence of endophthalmitis because You see, I don't want to lose the, you see, endospermity is not such a common phenomenon after injections that we scare the patient. Otherwise, though, all the anterior segment surgeons will stop surgeries because they operate on 6966. So that I don't think so is such a scare, you see, honestly. The other very good point Neha emerged was about the presence of neovascularization in patients who have PED and SRF. That definitely is a very, very good, indication for Octa. And the quantitative Octa, which is coming up now in a big way, not available in all the machines, but it will definitely have a role in follow-up of these patients with regard to flow indices and reduction in the size of vascular density and counseling the patients also. So any other point, Gopal?
Octa will basically replace OCT. Currently, OCT, over the next 4 or 5 years, I think Octa will completely replace OCT, and we are looking at newer algorithms and decision-making processes to treat, and probably I think the number of injections may increase till we get longer-acting injections or depot injections, which will stay for a year or so. Then Octa becomes irrelevant. Maybe once a year.
What machine do you have?
So the Topcon Triton Plus, the swept source Octa. So I did a lot of research before obviously making my own purchase, and like Dr. Gopal said, I sincerely felt it is the future. Rather, it's the present just merging into the future. And there are, I mean, this is of course no financial interest except that I have it. Compared to even the spectral domain of Heidelberg and Zeiss, I find the interface much better with the Topcon, with the swept source.
In this statement, you made 2 points. The kind of Octa you have makes a lot of difference to what you'll pick up.
Yes.
So sometimes, you may feel, why can't I see what Neha has seen? That's actually machine dependent. So we have to be careful about that. One more point I wanted to make. Adult Whittley-form lesions, very often mistaken for type 2 CNVM and treated again and again. Octa is a very quick differentiator for that also.
Yes, sir.
Thank you very much, Neha. A couple of days back, she phoned me with a low voice to say that she's completely coughing and she can't probably present today. Thank you for presenting. Sir, I think we need to make should we have Dr. Dinesh Talwar talking on?
No, I think let's finish this one talk only remaining. No?
That is a real world experience.
Yeah. I think
then let us go ahead.
We'll finish off with this and then we'll come to the clinical part of it.
Fine. Okay. So over to Dr. Rehna, who is again my colleague. She is consultant in vitreoretina with me, and she will present on real-world evidences in the management of AMD.
Because Dinesh is going to mesmerize the audience.
And anyway, now I'm not. After that, I'm available now. I don't have any time constraints. Yeah. If you have a time constraint, you have to see that.
Yes, sir. We will have a time constraint, sir. With Dr. Dinesh Talwar around, it will be definitely there.
You can go ahead. We can see your slides.
Thank you, sir. So my topic is real-world evidence in wet AMD. We know that treatment of neovascular AMD has evolved with the advent of anti-VEGF agents, and they have become the standard of the care. Randomized controlled trials have demonstrated the benefits of anti-VEGF agents in neovascular AMD. So what is the importance of the real-world studies? Even though the randomized controlled trial are the gold standard in medical research, providing evidence and efficacy in well-defined patient population, they have stringent inclusion and exclusion criteria, relatively small patient numbers, intensive treatment regimens, and limited duration of these clinical trials may not actually reflect the real-world experience. So the real-world studies actually explore the effectiveness of these treatments in real clinical practice, often with diverse patient population. So in this presentation, I'll be going through the real-world studies which were done on large numbers with anti-VEGF agents, mainly ranibizumab, aflibercept, and bevacizumab. I would not be touching on brolucizumab as there is a different talk, and also some of the treatments of polyps. So this is a Luminous study is a large prospective observation study, which was a study which was done over different countries across the globe to evaluate the long-term effectiveness, safety, and treatment pattern outcomes with intravitreal ranibizumab treatment in routine clinical practice. So this study recruited 30,138 adult patients across 5 approved indications, one of them was neovascular AMD, over 5-year duration. So this is different countries which were recruited in the trial, which include Canada, European countries, Slovakia, Australia, Japan, and China. And if you look at the results of the study, the visual acuity outcome at 1 year, you can see that the first bar chart, that is the global visual acuity gain, which is 3.1 letters, and the injection number, that is 5 injections. Mean number of injections at 1 year was 5, and the gain was 3.1. And if you look at individual countries, you can see that the China, the gain in visual acuity was 1.1 with the injection frequency of 2.9. And as the number of injections is increasing, you can see that the number of the amount of the visual gain is also increasing. Like in Australia, it is 8.7 injections in a year, where the visual acuity gain was 4.5 letters at the end of 1 year. And if you're comparing with the real world, with the randomized control trial like MARINA and ANCHOR, where the ranibizumab was used and the treatment was fixed dose regime, that every month for 12 months, where the number of injections was 12 in a year, the gain in visual acuity was much more than that of the real world study, LUMINOUS study, that is 6.6 and 5.4, and 10.7 and 8.1 in ANCHOR and MARINA trials, in contrast to the LUMINOUS study. So in the LUMINOUS study, 72.9% of the patients were receiving less than 5 injections. And if you compare the lot of randomized control trials with the real world evidence also, these randomized clinical trials include MARINA and the ANCHOR, which were actually looking into the ranibizumab fixed dose regimes, CAT trial, which looked into the difference between the bevacizumab and ranibizumab, the VIEW trials, which looked at aflibercept in neovascular AMD. And these trials, that is the TREND, the Call Harbor trial, which looked at different drug regimes like PR regime, fixed dose regime, or quarterly regime, or treat and extend regimes. That was these few trials. You can see that the improved visual acuity, the visual acuity gain was much better than the real world. And in here, the real world evidences, we are looking at FRB trial, that is, it's actually the 5 retinal blindness registry. The data was collected from that registry, and it was a large study involving patients from different countries across the globe, like New Zealand, Switzerland, and Canada. LUMINOUS study, we have already said, and AURA is another study, which was a retrospective study over 5 years. And UK EMR users group actually used the Medisoft software, and they recruited 20 different ophthalmology centers across England and Northern Ireland, and the data was collected from that. And we can see the difference. So if you look at this chart, the scatter plot clearly says that in real world, as the number of the injection increase, the gain is better. That is, visual acuity gains are associated with injection intensity, and the real world evidence is actually supporting the positive relationship between visual acuity gain and anti-VEGF injection frequency. So, but in real world setting, due to the treatment burden, clinical trial protocols are difficult to be implemented. And even the long-term visual acuity maintenance, you can see these graphs coming down after 2 years. The gain in the visual acuity is declining after 2 years, is because of the decreased injection frequencies. And the LUMINOUS study also showed that the patients who received the loading dose, that is injections which every month for 3 months, they were found to have better visual acuity gain compared to patients who didn't have a loading dose. So LUMINOUS study was actually supporting the loading dose for treatment of neovascular AMD. In the FIGHT FRB registry, this trial showed that what it was actually looking into this one of the this graph is actually showing how the baseline visual acuity is affecting the final visual outcome. So in patients, this is the first eye, this arrow that is about the first eye of the patient, and this is the second eye. So if the patient's visual acuity, baseline visual acuity is low, then they will have a better visual gain, but the visual outcome will be less than the patients with a better visual baseline visual acuity to start with. So this patients had a lower visual acuity to start with, gain was better, but the outcome was less compared to patients with better baseline visual acuity. And this is also showed in the LUMINOUS trial, where they showed patients with a better baseline visual acuity having a better outcome. And now into the real world outcomes with different regimes. So we have regimes like fixed dose regimes in MARINA ANCHOR trials, and PRN regimes which were tried in prior trials. And there are also treat and extend trials also. So in this real world outcome, this is a LUMINOUS study. Here, these are the visual acuity gains at 1 year, 2 year, and 3 years in the Luminous study. So in patients who were in the PRN regime, at 1 year, the gain in visual acuity was 3.5, but the treat and extend, it was 8.8. Similarly, at 3 years, you can see in PRN, there was a loss of 1.9 letters at 1 year compared to 5.4 letters gain in the treat and extend regime. And also, if you look at the yearly injections, it was more in the treat and extend group. That is 6.9 mean injections in the treat and extend group compared to 4.7 in the PRN. So this study showed that the number of injections required in the treat and extend or number of injections which were given in the treat and extend group was more than the PRN, but the number of the hospital visits were less in the treat and extend group. And the UK EMR data also showed the same. Actually, they were looking into PRN ranibizumab and fixed dose or treat and extend aflibercept. So in the PRN regime, there was a gain of 1.6 letters, but in the fixed dose of the treat and extend aflibercept, there was a gain of 6.1 letters. So this is more related to the more number of injections which were required, which was given in the aflibercept. But in this study, there was a slight initial rise in visual acuity in the loading phase with aflibercept than ranibizumab. Now, we will look at the real world outcomes with different anti-VEGF agents. So this is another study, real world study, which was done on ranibizumab in neovascular AMD and looking at the outcome between ranibizumab and aflibercept. And at 12 months, from this graph, it can be seen that the visual acuity gain, the final visual outcome was not different in the two groups at 12 months. There was no difference between the visual acuity change, injection frequency, and proportion of eyes, or proportion of eyes with CNV inactivation didn't differ significantly between both the groups. Similarly, the US EMR-based study. This study also showed the same. There was not much difference between the gain in visual acuity or the hospital visits or the injection doses. The difference which was found that this group, the first 3 bar chart group, is the non-PED group, and this is the PED group. So in the PED group required a slightly more number of injections compared to the non-PED group. And also ranibizumab group required more number of injections in the PED group compared to the aflibercept group, but that difference was not statistically significant. Now, this UK AMD EMR group, they actually looked at the visual outcome in patients with different baseline visual acuity, that is with good, moderate, and severe, and they found that the patients with the good visual acuity to start with, like 6.6 or 6.18 or more, they ended up with a good visual outcome. This is more like a long-term outcome at 3 years. So if you look at the first treated eye and the second treated eye, the second treated eye, of course, is diagnosed a bit more earlier. And so we can see that at the end of 3 years, they have a very good visual outcome. And this was important in the United Kingdom at that time, because earlier the NICE guidelines was recommending treatment of ranibizumab therapy for neovascular AMD only if the visual acuity is worse than 612. So looking at the long-term outcomes, that is 5-year outcomes of anti-VEGF treatment, this was a study which was done as a retrospective one with a 5-year follow-up. Here, the patients, all the patients who were on treat and extend regime, the patients on ranibizumab, bevacizumab, and aflibercept, they were compared, and they found no significant difference between the 3 different anti-VEGF in patients with wet AMD in real life world. And they also found that despite long-term treatment, there was a slight reduction in visual functions after 2 years of treatment. So now we will go on to the real-world studies in polyps. So there are randomized controlled trial which looked at PDT and anti-VEGF agents in polyps. The Everest trial has found that combination treatment of PDT and anti-VEGF is more effective in regression of the polyps and visual acuity improvement. And also Planet trial, which showed effectiveness of monotherapy with aflibercept. Here, this trials actually looked into the effect of anti-VEGF agents, this with ranibizumab and bevacizumab in polyps, and they found that is there is stabilization of vision and reduction in fluid, but limited effectiveness in polyp regression. And when they compared, another study which compared the aflibercept and ranibizumab injection for polypoidal choroidal vasculopathy, they found that the visual acuity gain is similar in both the groups. However, the aflibercept often led to polyp regression and ranibizumab. So this is similar to the PLANET study, which showed that aflibercept monotherapy can be similar to can cause polyp regression with aflibercept alone. And regarding the long-term efficacy and safety of PDT in combination with anti-VEGF growth factor for polypoidal choroidal vasculopathy, the long-term effect of combined treatment was found to be safe and effective, and it strengthened the superiority of combined treatment of PDT and anti-VEGF on a long-term treatment. So looking at the side effects of the anti-VEGF agents in real-world studies, this is a result from the LUMINOUS study, which showed that both the ocular side effect and the systemic side effect was no different from the randomized controlled trials. So now, what are the factors that underlie the reduced effectiveness of anti-VEGF in clinical practice? As we have seen from the previous LUMINOUS studies and other comparison between the real world and the RCTs, the mean number of injections range from 4.2 to 7.5 at 12 months in the real world studies. But the ANCHOR and MARINA were fixed dose regimes are used. The number of injections was 12. But that is an intensive treatment regime, and they may not be possible to apply it in the real world practice. And the schedule on which they are given is also influencing, and the monitoring frequency and retreatment criteria. So what are the recommendations from these studies that we can take? The need for sufficient treatment in real-world settings to achieve substantial gains in visual acuity during the first year of treatment. Fixed dose regime would be difficult to practice, but the regimes like treat and extend regimes would help to decrease the number of injections at the same time, give them as individualized therapy so that the visual acuity can be maintained on a long term, and reinforce the need for loading dose to achieve the best possible outcome. Prompt initiation of treatment is crucial in improving the visual outcome. Patients with initial good vision with early treatment will have good visual outcome, and the treat and extend regime will have has a potential alternative method of delivering the best possible visual outcome with the adequate number of injections. Thank you.
Wonderful, Rehana, because this is one area where, which is from practical viewpoint of view, a challenge. All of us, the anti-VEGF created revolution in management of neovascular AMD, and all of us were thrilled. One point which has emerged is loading dose. You have to emphasize, and because most of the patients, although we shift to treat and extend, but a lot of these patients are in the country are on PRN kind of regimen. Yes, so that is the biggest challenge we have, at how to maintain the initial visual gain. Although 5-year data which you showed, ultimately most of the patients continue to lose vision to say -1 or -2 letters, despite the initial gain, despite the regular injections also. But ultimately, our aim is to maximize the good seeing life of the patient. That is our ultimate goal. So, challenge is how to maintain this initial gain. I, for one, shift a lot of my patients on treat and extend rather than PRN wherever possible. We try to do that, depending on how much patient is intelligent and how much he or she listens to me and comes back, and if he has understood the disease, and if I've counseled them very well, because counseling plays a very important role in this. Because patients start, sometimes start doubting by why are you calling again and again. That is the biggest challenge we have. And as far as the agents are concerned, the 3 agents where maximal, data is available, all the 3 by and large do pretty well. You see, except that aflibercept has a definite edge over the other 2 agents, specifically over bevacizumab. So if patient is on bevacizumab, we definitely try to shift him to aflibercept in such patients, especially in patients who have polyp. With the non-availability of PDT now, we are totally dependent on aflibercept in patients of PCV or in patients who are poorly responding to bevacizumab also. So these, I think, are the key take-home messages that your talk was there. So any point, Gopal? Yeah, Dinesh? Dinesh, we'll hear your talk on.
Yeah, but I just wanted to make one point. Basically, when you keep in mind PRN and treat and extend, treat and extend means more injections for the same result. PRN means less injections, but more visits. Now, you have to balance. There are people who say, look, one injection can be 40,000 bucks, 35,000 bucks. So one visit may be only 3,000 bucks. So there is inconvenience of a visit, less cost, which has to be balanced against high cost, less visit. So if the patient says, look, I can't spend this much money in a year, then okay, then you come regularly. If the patient says, look, I want less visits, but spend what you want, then treat and extend comes. That is why in Western countries, treat and extend is very common because patient is not paying. Makes no difference to him. Whereas in our country, the patient is paying very often. When the patient is paying, if you want to optimize cost with efficacy, then PRN can be the better way. The problem with PRN comes if the follow-up is not done. I will show you now in all these aspects in the talk, but the basic issue that comes is, do we want more follow-ups, less cost, or less follow-ups, more cost, same results? Both will give you the same results. And this is the issue that every doctor has to see for his patient, and he has to discuss this and counsel with his patient when he goes about it.
This is the biggest challenge, I agree, DT. The problem which differentiates us from West is that majority of their patients are insured. So they are not paying. People who have to pay from their own pocket, every penny counts for them. So I agree with what DT has said regarding this. Gopal, any other point you want to make?
Sir, over the last 15 years, what learning experience each of us had is how to tailor the injections, the number of injections, the frequency of injections, the duration of re-injection follow-ups to each of these patients. Do you think that moving into the future, we are looking at depot injections, or filling it with like an ink pot, you're filling it with some anti-VEGF?
Are you talking about PDS?
Completely?
Are you talking about PDS?
Yeah.
Are you talking about PDS or?
Yes. So that will completely annihilate the need for any follow-ups like that, and it will continue on and on and on.
Gopal, the future is not this. The future is gene therapy for secretion of an anti-VEGF.
Mm-hmm.
Actually.
Yeah.
That is what is going to come finally, but it's going to take time. Yeah. And remember, it's not going to be cheap. You can understand that for RP, gene therapy is 6 crores.
Yes.
So it is what they will do is the money that you would have spent on anti-VEGF agents over the whole lifetime, they will take from you in the beginning, and then you will get the injection. So you will get your gene therapy. Your cost will not change.
Yeah. So gene therapy is as of today, and maybe for another decade or so, for ARMD will still be, if at all it comes, will still remain unaffordable. And we may not, and DT and me may not be live to see that in patients. But PDS has been approved because 2 refills are required in a year. That definitely does.
That will reduce the follow-ups. That will reduce the clinicians' insight into how you should retreat, etc., etc.
With PTS, the long-term challenge is going to be the risk of endophthalmitis.
Mm-hmm. Yeah.
You see, this is not like an IV cannula which is being put in which you have a container where it is contained subcutaneously. This is inside the eye, man.
Yeah,
a lot of difference.
That is the biggest fear, actually. This is the biggest fear.
Yeah.
But the proponents of PDS says that you see, if you...
Because so far we are talking of small numbers, 100, 200, 500 cases. When you're talking of terms of million cases, what is going to be the scenario?
Yeah. But if you hear to some of the proponents of PDS and the follow-up which they have had, the force with which they speak, and once you talk about endophthalmitis also, they are not much scared. We always are scared of this. But I also posed this question to a couple of these Western people, but I'm very much scared. There is a injection here which is hanging in the vitreous, and after 6 months you ask me to fill it up, which they say is an office procedure. The first visit may be a OT procedure, but this is an office procedure. I'm very much scared. I'm very much scared.
I think
With the same
a
reason.
better alternative is something like Ozurdex or Iluvien, where the drug is contained within a capsule, which is once given and it's over. There's no constant risk of an endophthalmitis coming up.
But uska role abhi AMD mein nahi hai na.
Yeah, but what I mean is that is
like drug.
Conceptually.
Sir, so
okay, I think
so the cumulative wisdom of all the people across the world was shown by Rehana's real world evidences, and probably the people who gets more injections are doing better in terms of number of letters, and irrespective of PR and treat and extend, whatever it is, the number of injections, if it increases the visual acuity in real world conditions increase. And to tell us more about how to optimize with maximal visual gain, with the least number of injections, with the least number of follow-ups, less burden to the patient, is my teacher, Professor Dinesh Talwar. Over to you, sir. You don't require any introduction. Over the next 30 minutes, let us hear you out, sir. Not more than 30 minutes.
Thank you. I hope I can finish in 30 minutes. And thank you, Gopal, and thank you to AMRITA Hospitals for inviting me here. Gopal is probably one of the finest students any teacher can have, and he's like he's a student who's a blessing for a teacher. And today he's not a student, today he's a teacher and probably even a teacher of teachers. So my respects to Gopal. I have learned a lot from him.
My God, sir, please.
So we've now discussed about so many aspects about age-related macular degeneration. Now let's come to actually using all that information to manage them. And in this topic, you realize Gopal has made one mistake. He is not mentioned about exudative ARMD. So therefore, I will discuss something else before I come to exudative ARMD also. This is my disclaimer and my financial disclosure. Now, you all know that this is a degenerative disorder, affects older adults. But as was pointed also, it could be non-neovascular or it could be neovascular. The important thing is, for any disease, can you prevent it? Yes. Maybe we can. And this is the aspect which was not mentioned in this talk. The point is that can we do prophylaxis? And now for the last 20 years, we know there is the age-related eye disease study, which shows that a combination of antioxidants can bring down the risk of advanced AMD significantly. The AREDS 2 substituted lutein and zeaxanthin for vitamin A with similar results. This is the only treatment which can decrease the risk of moderate vision loss also. So please do not consider that this is just a placebo. In patients with extensive intermediate drusen, at least one large drusen, non-central geographic atrophy, advanced AMD in the fellow eye, this is an essential part of your treatment process, which is ignored. Now you'll say, oh, what do we get? We get a 25% reduction in the risk of development of advanced AMD, which would otherwise happen in 5 years. Now you'll say, well, what is 25% reduction? To put it in perspective, control of hypertension results in a reduction of cardiovascular risk of 20 to 25% for myocardial infarction. Yet you have never said that do not take treatment for hypertension. But when it comes to this, you will give all kinds of glowing eyes and nice eyes and beautiful eyes, but you will not give AREDS formulations. Please stick to AREDS formulations for these patients, and you may save some of them. Now let's come to subfoveal and juxtafoveal exudative ARMD. Again, this is not a single disease. If you saw the pictures which were given of Marina and Classic, the results were different. They were better in Anchor than they were in Marina. That is because Anchor had predominantly classic CNVMs. Minimally classic CNVMs and occult CNVMs were there in Marina. And within occult also, there are different types. You can have late leakage from an unknown source, fibrovascular RPE detachments, and all these patients behave differently. Marina and Anchor showed us that the gold standard for treatment is monthly treatment with ranibizumab. But we all realize this is extremely intensive, exhausting, and not possible to do except for a minority of patients. So what is the way to go? Luckily for us, the SUSTAIN study showed us that there is a huge difference in the need for treatment for different patients. 20% of patients require only 3 injections and then may not need any injections for the rest of the year or 2. Whereas there will be another set of 20% patients who will require more than 5 retreatments. So if you select the patients, you can decrease the need for treatment. And that is what we need to do. Today, we have a number of options: ranibizumab, bevacizumab, aflibercept, and brolucizumab. And not only do we have different treatments and injections to various drugs, we have various schedules of treatment. You could have monthly, which was tried initially. You have 2 monthly and quarterly. You have PRN treatments, and you have treat and extend regimes. The important thing is that when you decide a particular treatment, you have to base it on efficacy, safety, ease of use, both for the patient and doctor, and the interval between the patients, between the treatments. Now, you say, what is more important, safety or efficacy? Somebody will say efficacy is most important, but it's not so. Safety is of paramount importance. Now, to bolster this argument, let me explain to you. The best, most effective, best in terms of most effective treatment for destroying a CNV, even today, is argon laser. Destroy the lesion completely, it won't come back. But is that what you want? 6 lines loss of vision followed by complete resolution. You don't want that. So you want efficacy with safety. And safety is the paramount importance. Now let's come to the treatment regimes. The first treatment major group was the EXCITE study, which found that that 40% of patients could be maintained on quarterly treatment with ranibizumab also. So to keep that in mind, 40% of patients need only quarterly treatment. But there is another 1/3 of patients with whom this quarterly treatment will result in a slow progressive decline. And this is what happens in majority. And then there is another 20% of patients who are the non-responders to this treatment. This is ranibizumab. So what happens with PRN dosing? The initial results were very promising. The Pronto study showed great results. Unfortunately, these were not replicated in subsequent studies. The Sailor study gave PRN treatment, but followed up every 3 months. Now note this, within 1 year, the entire visual gains went. So monitoring on a 3-monthly basis, PRN treatment, complete loss of all gains within a year. So then what is that? Is that really so? Yes. The SUSTAIN study changed nothing else. It only changed this into monthly visits. Retreatment criteria being the same. And suddenly over the 1 year, the visual results improved. So the first basic lesson, close monitoring is the way to sustain vision in these patients. And what are the things you watch in that? You look for not only BCVA change, you look for any OCT evidence of new fluid or persistent fluid, any increase in thickness, any macular hemorrhage. So the fundus photograph is equally important. Fundus picture is important. And most importantly, even if the physician gets this gut feeling, no, I think there's a little bit of fluid which has come back, it's an indication for treatment. With stringent guidelines for retreatment and monthly follow-ups, the PRN group can give you the same results as any other way of treatment. Then came the VIEW study for studying aflibercept, and they found that with aflibercept, 2 monthly treatments could also give you the same results as monthly treatment. So from monthly, you could go to 2 monthly treatment with fairly good results, as you see in the VIEW study here. While the VIEW studies were going on, people tried to see, can we improve the results with ranibizumab, and the treat and extend approaches came. The basic tenets of the treat and extend regime are: you give initially intensive monthly treatment till the exudation disappears. Then you extend the treatment interval by every 2 weeks up to 12 weeks, which is what is the maximum you're allowed to do with ranibizumab. If there is a mild recurrence of subretinal fluid or intraretinal fluid or any new retinal macular hemorrhage, reduce the interval by 1 or 2 weeks. Again, make the macula dry, then go back again. If the recurrence is more severe, you may even have to go back to monthly treatment. But if there is some persistent fluid, it's stable, then the interval is not increased. And the other important thing is that RPED is not, you don't go running after the RPED. If there is no SRF or intraretinal fluid, you can extend the interval even if RPED is there. Now, this was the principle which was initially used in treat and extend treatments. The Altair study followed more or less the same. It shortened the interval if there was persistent or increasing fluid. It maintained the interval if the fluid was decreasing, and it extended the interval if the fluid had dried off. But now you see the Hawken area. By this time, the concept of tolerating some fluid had increased. You can see here, there is no tolerance for intraretinal fluid, but stable intraretinal fluid may be acceptable. You will not, but if there is a little bit of subretinal fluid, you tolerate it. And you can see at 16 weeks, they have tolerated, if there is no vision loss, they have tolerated up to 75 microns. So up to 75 microns of SRF has been tolerated as long as there is no vision loss. The important thing is, during the discussion I mentioned, the treat and extend regimes are more proactive, number of injections increases. It's a good option for patients who are stable, where you want to increase the distance between the injections. Patients who have a dry lesion, they may be better off managed by using a wait and extend. That means you follow up on a monthly basis, but treat only when required. And that is a more reactive regime, and the risk of recurrence is, of course, there. Now, what is my learning over all these years? Which drug is optimal? I can tell you for type 2 CNVMs, ranibizumab is extremely effective. And you saw that in the ANCHOR study also. In type 1 CNVMs, aflibercept is probably better than ranibizumab. Overall, if you look at it, monthly bevacizumab also is almost as good as ranibizumab. But the macula dries less quickly and less often. This is from the CAT study. And brolucizumab is probably more effective in drying fluid, whether it's SRF, intraretinal fluid, or RPED, as you can see from this graph. In all three situations, this is for intraretinal and SRF, and this is for sub-RP fluid. Brolucizumab is probably a little more effective than aflibercept for these conditions. What about the safety? Both ranibizumab and aflibercept are equally safe. Bevacizumab, the only problem we've had is of cluster endophthalmitis. And that is the main issue. With bevacizumab, the only problem we've had is of cluster endophthalmitis. With brolucizumab, the basic issue is a 1 in 200 risk of intraocular inflammation and a 1 in 400 risk of an intra-inflammatory vascular occlusion. This needs to be explained to the patient before you start. The only thing to keep in mind in patients who have a recent MI or stroke, if you need to give, the only drug proven to be safe is 0.3 milligrams of ranibizumab. Now, the treatment regime also depends on the drug. With ranibizumab, you can do an extension of up to 7 weeks. With Altair, you can go up to 12-week extension in 60% of patients and 16-week extension for 40% of patients. Brolucizumab can be 12-weekly for a majority. Now let's come to actually how to manage. If you've got a patient, you give the injection at 3 months, after 3 injections, loading dose, patients dry. Now you have 2 options: treat and extend from here, or you can give monthly follow-ups and give recurrence, treatment for recurrence. I'll discuss that more. The important thing is that you can give any of the doses. You can give ranibizumab or aflibercept for this. And if the patient is dry for the next 3 months, monitor every month. If he's dry for the next 3 months, now you can increase the interval between the follow-ups to 6 weeks, 8 weeks, 10 weeks, up to a maximum of 12 weeks, which will continue. In patients who are one-eyed, this is where the fear is more, that you don't want to risk sudden drop. Treat and extend may be an acceptable alternative in these patients, even if they are dry. And if the recurrence occurs, you treat PRN, and then keep on treating according to need. And then if you find that you've learned how much time it takes for injection to occur, you can then consider going to treat and extend. Patients who need a PRN treatment with ranibizumab on a more frequently than 8 weekly, that means 4 or 6 weekly, consider aflibercept. The second group of patients are those whom after 3 injections are not dry. They still have some fluid, some little bit of intraretinal or subretinal fluid is there and it's stable. Continue the injections for another 3 months to see whether they dry. If they dry, go to PRN, what we just explained. If they don't dry, you can try a treat and extend regime in this group and extend the interval up to 12 weeks if you are with ranibizumab, and you can give more frequent injections if needed, or you can shift these patients to aflibercept. Now we've come to a situation where we've started using aflibercept as the initial loading dose. And if you're using this, we want to see whether we can do a better job. Now look what happens. You have patients who are, if the patient was dry, is one-eyed, I may want to decrease the total number of aflibercept injections. So I may try treat and extend ranibizumab. And if I can maintain that, I will do that. If I can't, I will go to treat and extend aflibercept. If aflibercept is being used more than 8 weekly intervals, you may consider a trial of brolucizumab for these patients. If both aflibercept and ranibizumab are needed 4 to 6 weekly, I would actually prefer ranibizumab because that is a safer drug. This is just to give you some examples. This is a patient in whom initially PR and ranibizumab given, but was requiring every 6-week injections, and so we shifted to aflibercept. And with aflibercept, we saw the recurrence started occurring initially at 8 weeks. We extended, went finally to 10 weeks, and we realized, very challenged, we found that after 12 weeks, the recurrence used to occur. So this patient was maintained on 10 weekly injections. This is another patient who was started with initiation with aflibercept, but unfortunately continued to require injections every 4 to 6 weeks. And this can happen. If this happens, you can go back and see, is the need for aflibercept and ranibizumab same? If it is same, then ranibizumab is probably the preferred drug. This is an important case where I'm just summarizes most of the treatments. This was a patient who got monthly Lucentis for almost 4 years without resolution, resolved quickly within 1 week with aflibercept. And then initially it started, the RPED began to recur after 6 weeks. And then the recurrence occurred at 9 weeks. So we were able to manage this patient on aflibercept initially, and it was at 8 weeks treat and extend. And then this went up to 10 weeks. And then we found that the regression started occurring. Initially 10 weeks, it started going back to 8 weeks. The recurrence started occurring. And then after some time, the patient said, why don't you go back to ranibizumab? We tried ranibizumab, and with ranibizumab, also we were able to take this patient to 8 to 10 weeks initially. And we shifted for some time to ranibizumab. And after that, when we got a recurrence, went back to Eylea, maintained him on Eylea, was able to take him to 16 weeks treat and extend. And then, but remember now, this 16-week treat and extend is not a straight line fashion. In real life, it comes and goes. You improve, you go down. And finally, now what happens? I'm sorry. And finally, this is what is important. Suddenly, because of Corona, he said no more. And then his last injection was at 16 weeks treat and extend. Twice that he got that. No treatment for last 20 months. Vision is stable. Was he cured by October 2019? Would we have been over-treating if we had given any more injections after that? Is it possible that if patient has reached 16-week intervals and has got injections twice, that's the time to stop the treatment? But that's something we need to explore. This is another, but this is the reverse side. This is a patient with 6/18 vision, has been on Eylea, 12 weekly treat and extend, but still, and despite that, now look at this. He was over here, and then you see this increase in RPD, which has bled from within, and now I'm increasing the frequency of his treatment. So even 12 weekly may not be adequate. And just looking at the fovea will not give you the answer. The fovea is normal, but look at this. The RPD is increasing, and finally, finally has become like this. So look at the entire picture. Don't go just at the foveal center. The last aspect is what to do when you're not getting a response to Eylea. This is a patient who's got one injection, another injection, a third injection, a fourth injection, and then finally, when we got no response, he was given brolucizumab. This is a brolucizumab switch. 1 day post-op, nothing happened, but 1 week post-op, the lesion had healed. The RPED is also almost disappeared. 2 weeks, great result. At 1 month, great result. Resolved almost completely. Now this patient was, I'm sorry. This is another patient where multiple injections of Eylea have been given. This intraretinal cyst refused to go, was given one intraretinal cyst, was given one brolucizumab. And with this brolucizumab, we got not much change in the first day, not much change on second day. By 1 month, few cysts were still left. I did not want to give him another brolucizumab immediately. So I gave an Eylea over here. The next month cysts were a little more, and then we repeated the brolucizumab at 10 weeks. And within 1 week, you can already see the cysts have become a little smaller. So now you can have a partial response or you can have a great response to brolucizumab. How should you switch? If the injection frequency with ranibizumab is less than 7 weeks for a recurrence, switch to aflibercept. If the injection frequency with aflibercept is less than 7 weeks for a recurrence, switch to brolucizumab. If you have a stable but not dry lesion, that means stable intraretinal cyst or stable subretinal fluid with monthly brolucizumab, switch to aflibercept. If you have a stable but not dry lesion with 4 to 6 weekly aflibercept, switch to brolucizumab. And if you're switching between brolucizumab and there is persistent fluid 4-week injection, I would try to increase the gap between brolucizumab by giving one aflibercept in the middle, so that brolucizumab is given at least 8 to 10 weeks later. Now, all this seems great, but what happened practically? Did the drug make a difference? As was pointed out in a previous report, no difference in visual outcomes or number of injections between all the 3 drugs. Aflibercept, ranibizumab, and bevacizumab in this study of long-term results. The fluid decrease, OCT showed decrease in both subretinal fluid and intraretinal fluid in all the 3 drugs with no differences between the agents used. What made the difference? The eyes which got more injections, regardless of what drug, they did better. And the difference is huge, almost 6 injections, 24 versus 18. The more the number of injections, the more the time injections continued. That means the more regular the follow-up, the better the visual outcome. And this is another study where ranibizumab was used as a fixed interval of 4 to 8 weeks. And you can see the results are way better than all other injections that we have. So this is the important thing. Ultimately, then this was discussed. So what is my talk? What is the approach? There are 2 approaches. Either you have no tolerance for fluid or you have some tolerance or tolerance for some fluid. I personally have no tolerance for fluid. Intraretinal fluid is not tolerated unless completely unresponsive. Subretinal fluid of up to 100 micron may be tolerated if you believe in tolerating fluid. Sub-RPE fluid does not respond to ranibizumab. So don't run after that if you're treating with ranibizumab. But increase in full fluid is not to be tolerated. This is the basic principle. Ultimately, the most important message is aggressive treatment is the key. And it's not, the treatment doesn't mean giving injection every time. Treatment includes monthly follow-up as long as the lesion is active, and then 3 monthly treatment follow-up lifelong. Greater number of injections, more intensive and more longer the follow-up, better the visual outcome. You can start with initial PRN, learn individually how often does the patient require injections, and then shift to treat and extend later on for that patient. But you must have a high index of suspicion for retreatment. Any loss of BCVA, any evidence of new fluid, if you are more aggressive, persistent fluid must be treated, especially if it's intraretinal fluid. Any new macular hemorrhage and any subjective evidence of your feeling patient is looking worse, treat it. Eternal vigil, my friends, is the price for maintaining vision in patients with CNVM. Thank you very much, ladies and gentlemen. That's it. Thank you.
Thank you very much, sir.
You can stop sharing. So I don't think so any question need to be asked after this exhaustive presentation, Gopal. Exhaustive presentation as usual by DT, clarifying each and everything. Still, I will be compelled to ask some questions, and then I'll ask Subhendu also to pitch in. You see, fluid we had discussed when Vasumati was presenting, that no tolerance or zero tolerance for IRF. And for SRF and RPE, if it is stable and not associated with decreasing visual acuity or not increasing, then 75 to 100 micron you can. The other thing is today, Dinesh, I'm asking you directly, aflibercept is the first choice, considering the reason I'm asking this is because there is an ILIA for You program running, which makes it economical also. It is effective, there's no doubt. We don't have PDT. It takes care of, because Gopal was initially talking about a subset of 25 to 33% of PCV patients, which definitely responds better to aflibercept than to ranibizumab. So considering these 3-4 points, should this be the carry-home message that aflibercept can be considered as a first line?
For me, the first line treatment for type 2 CNVM is still ranibizumab. I can tell you, and in fact, just even recently, I've had patients who ask me, why are you giving ranibizumab? Why are you not giving aflibercept? I don't give aflibercept in type 2 CNVM as first line treatment because I believe for Asian patients, it's a little more aggressive treatment than required. The chance of geographic atrophy is more.
For type 1?
For type 1 CNVM, I start with aflibercept now, then see how the patient is proceeding. I told you there are some patients, which is very unfortunate. There are some patients on initial aflibercept who do not respond. I showed you one patient also.
Yeah.
When that situation is reached, then I try to do a switch to ranibizumab and see if the frequency of requirement for aflibercept and ranibizumab is the same.
It's same. You see, you showed 2 examples of switch to brolucimab.
Yeah.
You see, obviously, 1 day response is too much to expect.
No, 1 week is what. No. Yeah. I've shown you follow up till 2 months.
Yeah. So, but the second patient where it did respond and you shifted it back, not to brolucimab, but to aflibercept, I would have still given the option of brolucimab because it has shown the effect.
Yeah. So what I did was the first patient got a great response to brolucimab. So there I wanted to increase the duration between the injections.
Yeah.
So I did not give, so the second was like a treat and extend of aflibercept as a maintenance. And then if required, he can go to brolucizumab. The second patient had not responded completely, but by then these reports of
inflammation
problems with more frequent injections had come. So I wanted to increase the duration between the injections. So I gave an aflibercept in the middle and then went back to brolucizumab again. And it started responding a little better. But you see the difference. Two patients, one beautiful response, the other not a good response. And
so number of patients are too less to
the message is also intraretinal cysts. Intraretinal cysts are more refractory to treatment.
Obviously.
Subretinal fluid is very quick to response.
You see, with brolucizumab type 1 sub SRF and sub RP fluid goes like jadoo actually with brolucizumab. There's no doubt about it. Therefore, I have been always telling if it is type 1, brolucizumab can become a very effective agent for this. The other point I wanted to ask was this about the retreatment criteria where you said hemorrhage, visual acuity, and fluid. This subjective macular fluid I could not understand.
I'll tell you.
This is subjective.
I'll tell you.
That is very
see, what happens is when early intraretinal cysts start appearing, sometimes they are very small. So the thickness doesn't show any obvious increase. But if you look carefully at the morphology, it seems one has a more solid looking retina, more coherent retina. The other has more cysts within it. It's like a little bit of sponginess starts appearing in it. If that feeling comes, it will not fit into any criteria. It will not be 100 micron. It won't be well-defined cysts. It won't be well-defined SRF. But you know this is not what it was before. If you're in that situation, you could be proactive and give an injection. And you will see, actually, the patient will say, I become better.
Okay. The other thing is, I do agree that you see loading dose, treat and extend is one of the best regime, which is proactive. Treat and extend is not bad, not bad, provided patient is intelligent enough to, obey your directions. Yes, Subhendu.
Yes, I have a question to Dr. Talwar, sir. Sir, is there any criteria when you should switch over to the other agent? Is there any fixed formula that after you're given first injection, no response, second injection, no response, then even only you have to give the third injection, or you should choose?
Yeah, I was reading some studies which said 3 injections, but I would say 3 OCTs. 2 injections, 3 OCTs, no change is a good indication for making a change.
Okay.
After the loading dose. After the loading dose.
After the loading
dose. No change. Aim is no change or some change?
No change. If there is no change, no change in vision, no change in fluid. See, if your fluid is decreasing, but it decreased a little bit, it's still improving. So it's not a non-responder. Non-responder is no change.
So I think all of us agree with
injections. No, that means 5 injections you will do.
No, initial loading dose is over. Yeah. So the third part of the third injection, 5 injections, third injection of the loading dose, and 2 more injections before you say no. You have 3 OCTs which say nothing is happening.
So this is all agreeable. I think the point is people are still scared for the reason what you said, 1 in 200 inflammation and 1 in 400 vasculitis of brolucizumab. But there are nearly 10,000 injections of brolucizumab already being given in this country.
The figures are from there. These figures of 1 in 200 and 1 in 400 are from there only.
Yeah. So I agree. It cannot become the like you said, we all start with routine anti-VEGF agents. And today, for me, actually, aflibercept has become number 1 because of economics also, and because of coverage of PCV also. I'm talking of total overall AMD population, not isolated, excluding PCVs, and because of this ILIA for use scheme also.
Yeah, Lalit, the good thing about last 2 slides, the reason I wanted to stress on them was because don't be disappointed if you say my patient can't get aflibercept. Because the biosimilar of ranibizumab will also over the long term be able to save you in majority of patients.
Yeah. Biosimilar.
Right? So this is one message. And for those who say I can't even afford the biosimilar of ranibizumab, even the biosimilar of bevacizumab will save you.
Yes,
So
some
please
treatment is
do
better
not,
than nothing.
today, the important thing is not to miss the treatment for anyone.
So let me ask you this final question. How do you counsel your patient when a treatment naive patient has come to you for the first time in OPD? What do you talk to him?
Okay, so today, because the cost difference between aflibercept and ranibizumab is not there.
Yeah.
For type 1, I do not, for type 2 lesions, I don't offer the choice of aflibercept. I just tell them ranibizumab is the drug we'll be using. For type 1 CNVM, I give the patient the choice between, I tell the patient that this is there. Here, you will have to make a certain amount of extra money payment initially, but you get the patient support program. So if you can afford to make a lump sum payment, then this is a better drug for you. I actually say this is a better drug for you. If you can't afford that lump sum payment, then we have to shift to ranibizumab. And then I give them the offer, and then I tell them that ranibizumab is also available as both the innovator drug as well as the biosimilar. So you have to tell me what is the cost level at which you can afford the treatment. It's not going to be a single treatment. It is going to be, and I also tell them that it may look funny. I tell them this is a lifelong treatment. Except for 20% of patients who require 3 injections and don't require injections for the next year or 2, most patients will require number of injections varying from 4 to 12 per year. And this will continue as long as you live. And if I die, please find another doctor. It doesn't look nice to say you died.
God initial prognosis, I said.
That patient will follow you to heaven also.
Throughout his whole life.
Prashant, you have any difference from this, what he said?
Sir, Talwar sir says the final word. It's always the final word.
Yeah, Gopal, I think
sir, I think we should move on. This has been discussed
great
really
talk
well.
As usual, DT, with hardly any questions. These are some clarifications which I thought will, summarize some things which you have already told. But honestly, there were hardly any questions to be asked. Great.
Now let's talk about the new kid on the block. I would definitely like to move to brolucizumab as a first-line agent. If so all those...
DT, you should stay on.
Yeah, I'm here.
Yeah. So for that, for bringing in brolucizumab, I have 2 eminent speakers. One is Dr. Prashant Bavankule, who is very busy. He's in the midst of 3 meetings right now.
Oh.
And a couple of physical meetings as well. And he is here from Nagpur, Sairakshi Netralaya. Over to you, Prashant.
Thank you, Gopal. Okay. In fact, very truly said, today we are having a physical meeting in one of the state ophthalmic society. And so I'm as excited as that, basically because it's fun to meet everyone rather than being virtual. Okay, we will be talking today about
Prashant, the voice is somehow not clear.
Prashant,
yeah.
I think you should just cut off your video.
Video, okay.
Video, you just cut off your video because it doesn't, the connectivity speed is less.
Yeah, I can understand. Is it okay now? Can you see me?
Yes. Please continue.
So this 45 years female complained of decreased vision in left eye of 3 days duration. And this was the fundus picture. You can see on a white field photograph, a cystic swelling at the macula. And the OCT showed double hump sign with some amount of fluid. The patient's vision had reduced to 6/60. And this was the angio which was done and the ICG which showed a small leak. At that point, we decided to treat this lady with aflibercept, and the aflibercept was continued at Q4 interval, 2nd, 3rd, 4th, and 5th. The 4th and the 5th were given at Q8 interval for this lady. But somehow the PD or the swelling was coming and going. And this was the picture at 9 months after 5 dosages of aflibercept. It had assumed more of a orangish hue, suggestive that it has become more hemorrhagic in nature, and the vision and the OCT was as bad as it was before. So at this point, we decided to changed the molecule as the patient was becoming more symptomatic, and we introduced brolucizumab at this point. And within a month, within 4 weeks, this is at Q4 after first brolucizumab, you can see this orangish hue has become more organized and become more yellowish, suggestive that it is changing the nature, and the OCT showed flattening. We continued at that point with loading dosages of brolucizumab. Second and third brolucizumab was given at Q4 interval, and the vision had moved from 636 to 618. And this is how we continued. This is the follow-up of this patient at Q8 interval. And then the fourth injection was given at Q8 interval, and the fifth was again given at Q8 interval. And this is the short timeline for you. Before introduction, this was the picture, and this is after Q8, and this is the flattening which we could see. And now the patient had gone back to 612. This is a 54 years laparoscopic male who was with me since 2010. And this was the presentation in 2010 when he complained of decreased vision in his left eye. And this was the angio OCT corresponding. At that point of time, we only had ranibizumab as a molecule, which we gave him as loading dose at Q4 interval. And then patient went into remission. And he had gone back to 612 parts. 2 years later, he had a first recurrence when again you can see the hemorrhage over here, and the vision had dropped from 612 parts to 624, corresponding angio at that point, again treated with ranibizumab. This is 1 month after the 3 loading dosages following first recurrence. So this is the picture you can see after recurrence, 3 ranibizumab was given. So after 3 injections of ranibizumab, after second recurrence, patient had minimal cyst, minimal fluid, and he had accepted that his vision is not going to improve. So he said, let's continue watching. My right eye is better. Let me continue. I don't want further injections. Now, this is the picture for you. Now, 4 years after the second recurrence in left eye, he complained of decreased vision in his right eye. And you can see now there is a cystic swelling and OCT corresponding there. And here it showed almost a scar with some degenerative fluid on OCT in the left eye. We went ahead with aflibercept in right eye. 3 loading dose was given. And this is the picture you can see, the timeline for you. Multiple injections were given, almost 5 injections of aflibercept, but the swelling came back with vengeance, and his vision had further deteriorated when we introduced him with brolucizumab in that eye. We were really skeptical at that point of time because being a laparoscopic surgeon, being the only eye, we went ahead with this, and this is first day after Q4. You could see the flattening of the PED. Second brolucizumab as a loading dose at Q4 interval. Then again third brolucizumab. We went ahead with loading dose of 3 injections. And this is the picture post 3 loading dose. His vision had resumed or gone back to 6 parts and near flattening on the OCT. And this is what has happened about this other eye, Q8. And then after Q8, we injected him with the 4th brolucizumab when we thought further there is a fluid. And at 5th was given at Q10 when we saw some fluid. So this is the timeline for his right eye, which was the better eye in this last 10, 12 years. And this is how the picture has behaved. Now, after initial treatment of brolucizumab, patient was so convinced about the molecule, he said, doctor, let's try the treatment even in the left eye, where we thought this is a scar and this is a degenerative fluid where it will not help us. And to our surprise, at Q4, patient 636 vision for last 4 years was now 618, and the fluid had dried. When we introduced second brolucizumab here, and this is what we did for the left eye, which was 636 vision with a so-called scar and a degenerative fluid. And this is at Q10 interval when we injected third brolucizumab. So this is just a timeline for you. So-called degenerative fluid with a scar responding, and the patient's vision moving back from 636 to 612 was a surprise to us as well. Now, bolstered by this experience, we decided to experiment this molecule or try this molecule in certain naive CNVMs. 78 years female. This is the picture at presentation, fundus picture, and the OCT corresponding showing that FFA and ICG. Directly we went ahead with brolucizumab, and this is second brolucizumab, third brolucizumab at Q4 interval. And you can see the timeline and how the patient behaved and his recovery of vision. Case 2, This is a bilateral CNVM you can see in this particular case. He had bilateral decreased vision. You can see the corresponding OCTs and color photos, angios. And at that time, we decided to inject in both eyes brolucizumab, but we gave at an interval of 3 days. And this is how it started responding. 6 weeks post first injection. OCT, you can see the left eye had near flattening. Second dose was given in both the eyes 6 weeks later. And this is 6 weeks post second injection. And you can see at that point, we thought left eye is near dry. So we decided to observe while we went ahead at 6 weeks with the third dose in right eye because we wanted further flattening of this ridge. And this is the picture you can see 1 month after third brolucizumab. And this is further. Then after 3 months after the last dose, he had a recurrence in left eye when we injected him further brolucizumab. And this is the timeline for you in the right eye. And this is the timeline for you in the left eye. Based on this, we have started using it extended indication. She is the mother of a pathologist who presented with a peripheral PCV with fluid in the dripping into the macula. Large peripheral mounts were there. You can see the hemorrhage here. And so in this, and this is the OCT, the height, the OCT going through the lesion in the periphery. And this FFA ICG was done. We went ahead directly with brolucizumab. And you can see the picture, second, third, fourth. And I will just run through it. I will just show the timeline for you, how the flattening is there. And now it is more than 5 weeks that the patient, 8 weeks rather, it has nearly flattened and the patient is back to 612. Thank you. This is our short experience with this molecule. Thank you, sir.
So Gopal, can we, have Shubhendu present again, then we can discuss?
Yeah. Okay, sir. Okay. Over to Shubhendu, my batchmate and the real great vitreoretinal surgeon from Disha, Calcutta. He has won more awards than I can count in videos as well as papers. Over to Shubhendu, please.
Thank you, Gopal. Thank you, AMRITA Hospital for arranging such a nice webinar. So coming to my talk, my real world experience with this new drug after Dr. Prashant Bankula's talk. This is also, I'm sharing my experience with this brolucizumab in this era of a lot of anti-VEGFs, where you can see from the ranibizumab, bevacizumab, aflibercept, giflibercept, pombercept, and now latest addition brolucizumab. The main difference is the size of the molecules. So how we retina specialists are going to capitalize the new features of this new drug brolucizumab because of its structural uniqueness. It is a single chain antibody fragments at the smallest functional unit of the antibody, and allows deliveries of a greater molar dose compared to the larger molecule. If you compare this one molecule of aflibercept, it is equivalent to 0.5 molecules of ranibizumab, which is equivalent to 11 to 13 molecules of brolucizumab. So it allows the faster penetration to the retina and the potential for more effective tissue penetration. Faster penetration means less than 6 hours. Most of the other drugs like ranibizumab more than 6 hours, and aflibercept can go extend up to the 24 hours. So it increases the duration of the action because it accumulates into the subretinal sub-RP space where the culprit CNVM is there. So it is responsible for the extended dosage regime. So how we can assess the effectiveness of an anti-VEGF drug? It is the intraretinal systolic changes, subretinal and sub-RP fluid. So recently we have performed, already did the brain study, the brolucizumab in neovascular age-related macular degeneration Indian real-world experience, where the real-world clinical data of intravitreal injection of brolucizumab in the management of neovascular AMD in Indian eyes has not been reported. So the purpose was to assess its efficacy in the Indian eyes under real-world conditions. So we treated in both treatment naive and treatment switch therapy patients also, where we are given injected brolucizumab 6 mg, and where outcomes are measured of BCVA, macular fluid, CST, PED, and safety. So total number of injection we are given in 126, and mean number of injection of 1.36 plus 1 standard deviation. Mean follow-up was 7.3 plus 1 standard deviation weeks after first injection, and patient who received more than one injection, mean time to the next injection was 10.2 weeks. So the visual acuity improvement, vision improved in both treatment naive as well as switch over patient, and there is significant visual improvement also in the both in the cohort also. So significant reduction of CST was found in both groups as well in the core groups, and notable fluid reduction was noted in both groups, both treatment naive and the switchover patient, and there is no there is no IOI or serious adverse reaction was noted reported in our study, except one case of RP and one subretinal hemorrhage case. Representative of one case, the duration baseline after 4 weeks, after 12 weeks, after 8 weeks, you can see the gradual reduction of not only the fluid, but also there is hardly any recurrence has been seen. Also in treatment naive patient, complete SRF resolution was seen with this mechanics. You can see the subretinal hyperactive material is gradually decreasing, and it is finally at the end of 24 weeks totally resolved. So key takeaway messages, it's efficacious. This real world outcomes of reduction in eyes for neovascular AMD patient, it's efficacious, safe in both treatment naive as well as switch therapy patient. So significant BCV improvement, so significant CST reduction, notable fluid reduction, as well as no IOI reported. So coming to my personal experience, case one, it was a treatment naive patient. Patient presented to our hospital in 2015, where he came with a little bit of subfoveal hemorrhage, and the left eye was absolutely normal. Vision was 6/12 pulse. Main complaint was distorted vision. We advised him for the digital fluorescence angiography as well as the OCT basic investigation, but he didn't turn up. It came after 4 years. So where you can see there is hardly any hemorrhage, but the PED and little bit of overlying retina was boggy. I advised him to take the ranibizumab, but he didn't again turn up after 1 month. So he came with the 6/18 vision, where we have advised him for to go for any choices. Kept all the choices, but he took and the other way is also normal. He took the ranibizumab, and after 5 weeks of this ranibizumab injection, you can see there is notable reduction in the bogginess of the retina overlying the PED, and you can see the fluid is gradually decreasing, and it was after 11 weeks or so. This is quite stable, no reappearance of the fluid or the hemorrhage, and after 20 weeks also it was being absolutely fine, but after 24 weeks you can see that there is recurrence, and we advise him for the second dose, and he was doing fine after that till now. So coming to my second case, it was a stable, and the right eye was absolutely fine. Left eye was the subretinal hemorrhage, you can see, and vision was 1/60, and occult CNVM, although he was a diabetic, but not much of DR changes. Vision was 1/60. So after taking 6 injection of ranibizumab, 2 injection of aflibercept, the vision stabilized to 6/24 parts. But again, he came with the recurrence of cystoid changes and elevation of PED in the month of October 2020, where I advised him for this injection, and after taking this injection after 3 weeks, you can see the fluid has totally dissolved, and the junction between the neurosynaptic retina and the PED is almost, it is getting fuzzy. That means that the CNVM part is regressing, and vision improved to 6/18, and you can see it was getting stabilized till 16 weeks and till 24 weeks also. But 28 weeks, there is hardly slight recurrence of SRF, so we are advising for the second dose. So after 7 months, I have advised him. Until now, he is doing fine with this second drug. So that means you can use it as a PRN basis, not as a fixed dosage of the monthly injection. So coming to my third case, it was a post-vitrectomized eye. I treated him with for the vitrectomy and subretinal hemorrhage, but due to the scarring, subretinal sections and scarring, the vision improved not much, but still the patient came with some amount of fluid, intraretinal cystoid changes. But after 2 weeks of giving this the drug, the cystoid changes hardly gone, but that solid PED and the scarred membrane is still persisting. Coming to my fourth case, where the bilateral stable CNVM after taking multiple injection of ranibizumab, but after even in spite of that, but there is recurrence in both eyes, SRF in the right eye and left eye. It was PED has increased and a slight amount of SRF. Vision gone down to 6/18 and 6/12. After 3 weeks of giving injection, they can see the SRF is totally gone, and PED height and width of the PED is total is almost regressed, you can see. Coming to my fifth case, where there is recurrent CNVM, SRF is there, a stable CNVM from 6-9 parts to 6-18, you can see, but after giving this single injection of brolucizumab, you can see the SRF is totally resolved, PED is also regressed much, and the OCT angiography also showing hardly any active CN membrane. Coming to my sixth case, it was also a case of like a stable CNVM after taking multiple injection of ranibizumab, but the patient came with the recurrence of CNVM with a high increase in PED as well as SRF. You can see recurrent CNVM, and after a vision was, although it was quite good, it is 6.9%, otherwise doing fine except the NOST PED. No fluid, no other fluid, SRF or interrectal cystoid changes. So yeah, in the left eye, you have given the brolucizumab injection. After 2 weeks of this injection, you can vision improve to 6.9. And after 6 weeks of this injection, you can see the PED part has also gone down significantly, and SRF is not recurring. Coming to my seventh case, it's again a case of recurrent stable CNVM after giving this injection 2 weeks. You can see the vision improved, SRF decreased, PED part slightly decreased, and no more cystoid changes, and hardly any cystoid changes, and it was being fine till now. And coming to my eighth case, it was a case of one-eyed patient, also left eye advised for the hemorrhagic VR surgery. Did the VR surgery for the hemorrhagic retinal detachment, but other eye is having a lot of that is asteroidal and old CNVM, solid PED, but there was recurrence in spite of this old CNVM. There is recurrence of fluid and PED part, but still after giving this injection, this SRF and PED part is almost, it is resolved, but solid PED part is persisting. Coming to my ninth case, where there is recurrent CNVM after taking multiple injection, but still the SRF and PED is not that much, but vision gone down from 6.9 to 6.12 parts. After 6 years giving this Paganex injection, vision improved to 6.9, SRF and PED parts are also getting resolved. But he was doing fine until 14 weeks. So yeah, after 14 weeks, OCT, when it was showing SRF, recurrence of SRF as well as PED part slight increase, we have given the injection, say, advice for the second dose. Coming to my 10th case, it was past history of ranibizumab before the doses in each eye, but there was a recurrence in SRF as well as cystoid changes. After giving bilateral both eye this Paganex injection, this SRF as well as the cystoid changes has almost resolved. And after 8 weeks also, it was doing absolutely fine. You can see the OCT changes is almost stable, but the PED, it is persisting, although Dr. Talwar was saying the PED, if it is not increasing, don't run after the anti-VEGF giving anti-VEGF injection. But if it is increasing, that means the reappearance of fluid, then you have to inject again. So it was a stable CNVM, stable PED, but I have not injected this injection. So far, we have given more than 650 injection, and we have faced adverse reaction in 2 cases. One of my colleagues faced both the panuveitis like features along with vasculitis. Vision gone down in that case 624 to 3/60, but after systemic and topical steroid and cycloplegic, the vision improved to 6/24 again. In my case, there was appearance of KPs and AC cells per 1+. After the second injection of Paganex, after first injection, it was not doing any reaction, but after second injection, because maybe there was antigen antibody reaction, it was sensitization to the drug already happened, and after giving the second injection, the reaction reappeared. So vision gone down from 6/12 to 6/24. Now, after treating this only topical steroid and cycloplegic, prednisone acetate and atropine, this vision improved to 6/12 again. And I have to for the recurrence of this injection, for recurrence of CNVM, I have advised him to switch to the ranibizumab again, to the not to continue with this brolucizumab. So as it is a new drug, so we should still use it judiciously. Hardly we have just completed more than 1 year, just completed after September 2020 to till now January. It's 1 year, 3 months. So still, I think 2 years is good enough to assess any new drug. So as it is really a miracle kind of drug, so you should still use it judiciously, avoiding one patient, but still explain the patient, should take the proper consent, and although it is quite difficult, but frequent follow-up is initially necessary so that we can later on increase the duration of the drug to the injection. Thank you.
Subhendu, very nice talk. We can stop sharing.
Yes.
You see, you said it's a miracle drug. And your experience based on 600 plus eyes and only 2 patients of...
More than 650, yes, sir.
Yeah, of IOI. And that too resolved on topical steroids. So today, I think majority of us in the country, in this country, I'm talking primarily because is that people do not hesitate in patients who have recurrent or non-responders. There's no doubt that people will shift, will try, will explain, counsel, special consent form, that will be done. But how confident are we today to start in treatment now? That is the biggest burning issue. Because of its excellent response. You see, I was very fascinated to read this Braille study of 126 injections. No inflammation at all. So that is in contrast to, you see, there are a lot of other reports from country also. No inflammation. Is there a genetic factors coming into play? Or because we are treating less aggressively, we are treating only on PRN, we may not be giving, you see, the regular proposed by Hawk and Harrier that you give. You say, remember that Merlin study, which had to be stopped by Novartis, primarily because it was a very aggressive study, every month. So how confident are you in recommending it as the usage increased of brolucimab compared to other drugs in, I'm talking of naive patients, in resistant and recurrent, there's no doubt.
You said 2 things I have to say, like if you want to continue with the other, like you want to continue with the like a fixed dosage regime, like other drugs or previous drugs, you can use it 2 monthly injection. But practically, this is the drug where you can use it as a PRN basis also. It is also in case of treatment-naive patient. But some stalwarts from our country that they are recommending also that 2 monthly injection is good enough for the treatment-naive patient. But if it is recurring, then go for the PRN basis. This is I don't know what should be the some kind of multicentric trial should be like, whether it should be followed as a PRN basis or the fixed dosage regime. So two arms should be we should give the options for the patient.
So whatever I have treated, although not a very high number, but it's primarily PRN basis only.
Yes, sir.
And majority of these patients have type 1 kind of membrane rather than type 2. Type 2, I still would depend on conventional aflibercept or ranibizumab. But for type 1, you see, I do give the option of brolucimab, especially if it is a resistant or a recurrent membrane. There is no... regarding the fear, how much afraid you are today for IOI?
Sir, for one-eyed patient, I'm really afraid of IOI, but for both eyes, I am not. I have to think twice for one-eyed patient. That is the thing. But because I have seen one case of IOI.
And have you seen any vascular block?
Vascular block, one of my colleagues has seen the vasculitis, but no vascular block, no arterial block. So what
was the fate of that eye ultimately?
That has improved with the oral and as well as oral drug. Oral steroid has to be given in that case.
So let me ask one blunt, direct question to everybody, Gopal, Dinesh, and Subhendu. Led by Subhendu, what is the current status of brolucimab today in our country? Subhendu?
It is I think it is going to be the first line of treatment for all kinds of CNBF. I think so. It is going to be, still it is not, but just before that, eccentrics, maybe the ranibizumab was the first line of treatment, but it is going to be the, like, it has huge potential, I should say. It has huge potential.
And people, Gopal, your take. We'll come to DT in the end.
This is the most efficacious drug, no doubt.
Yes, no doubt.
Can you, your voice, Gopal?
Oops.
Yeah.
It's not clear?
Now it is
Yes,
better.
clear.
Yeah. So this is the most efficacious drug, no doubt about it. Our only problem is about the documented side effects that we are seeing, and especially that is what is bogging our mind. And from the Indian,
Gopal, honestly
from the Indian,
people get scared by the label.
Yeah.
Label mein hi likha hua na 4% incidence. That is what scares.
Yeah. So as more and more Indian evidence come out, like Shubhendu said that in 650 cases, there were only a couple of cases and there were only topical steroids. Like that, many more people come out with their own statistics to say that the side effects are not too many. Then I think this will become the first drug of choice.
In all across CNVs, irrespective of resistant, recurrent.
At least the chronic and the treatment naive. Yes, I think so. Because one of the important things would be to reduce the burden of treatment onto the patient as well.
Yeah, that is the biggest, you see, gain. That is the biggest gain. Although aflibercept also has that, 60%.
But this is much better than that.
You see, aflibercept somehow does not flatten the RP. Aflibercept does not uniformly takes care of SRF and also sub-RP fluid. But this miracle drug actually takes care of all these three components. Very, very nice.
Yes. Yes, sir.
So that is true. Therefore, in treatment, in patients who have type 1 or suspect of, say, PCV, this should become number one choice.
Sir, in type 1, aflibercept flattens the PED more than ranibizumab.
Ranibizumab, yes.
But as you said, it is not completely uniform, not in all cases. That I agree.
Not in all cases. Yes.
Yeah.
I don't have enough experience in Paganex to say that all the PEDs will be flattened. Based on many of the images that Shubhendu and Prashant showed, some of the PEDs are remaining there, even with brolucizumab.
You see the confidence with which you can say today that will you choose aflibercept vis-a-vis this in patients who have PED and SRF? I think my first bet will be on brolucizumab because it does it more effectively, more frequently than aflibercept. So anybody else? Yes, DT?
Before I give you my comments, I want to ask one question from Shubhendu. The patients where you showed a switch from had received multiple injections and then we gave Pagenex, was the switch from ranibizumab to Pagenex or was the switch from aflibercept to Pagenex?
Most of the cases, it was ranibizumab to Paganex. Few cases, aflibercept to Paganex.
I think he showed both the examples.
The reason I asked you this is because the fact is that just shifting from ranibizumab to aflibercept can cause in many patients same resolution which you're seeing with Pagenex. Yes. So that is why I believe it's a sequential thing. Now, just to put things in perspective, 40% of patients in the EXCITE study 15 years back required only quarterly treatment. Keep this in mind. And what are you claiming with brolucizumab? Quarterly treatment. Now let's come to aflibercept. 60% of patients with aflibercept can end up with quarterly treatment. Right? The point is there are only 30% of patients who do not respond to any kind of treatment. Start with the EXCITE study, the SUSTAIN study, 20% non-responders. Go to VIEW, you'll find the same numbers. Go to ALTAIR, you'll find the same numbers. And come to brolucizumab, there are 30% patients who do not respond finally. The miraculous results we are talking about are a small fragment of the non-responders to ranibizumab and aflibercept. So there are non-responders to. So supposing I want to do a case selection, right? Would I put my best foot forward, knowing that it's a lifelong thing? If in treatment naive patients, I start off with brolucizumab, I am taking the risk of brolucizumab in 70% patients who would not need that treatment. Keep that in mind. Of the 100 patients, let's treat take treatment naive patients, take 100 treatment naive patients. 70 of them, actually, I'll go even further. 30 of them would have responded to ranibizumab completely. Another 15-20% would have responded to aflibercept completely. And now with brolucizumab, the additional amount would be another 10% or so. For the 10% extra, am I willing to treat 90 more? This is my point. With a drug which is not as safe as ranibizumab. I'm talking of ranibizumab now. So my first starting point is ranibizumab. It's the sweet tooth, is the sweet point, is the sweet point which has maximum safety, minimum risk, and maximum experience. So type 2 CMVM, first of all, type 2 CMVM, no question of going to anything else.
Yeah, that we 100% agree.
Right?
And that
now
type
1 CNVM, type 1 CNVM, there will be some 20% patients who would have responded, or 30% patients who would have responded very well to aflibercept. Why should I not take that advantage with aflibercept, which has shown greater safety? And then the ones who don't respond, after 3 injections, 4 injections, I can always come to a brolucizumab and put them on, as you said, PRN. I don't even need to put them on a regular treatment and get the effect of almost 12 weekly advantage, or even 10 weekly advantage. I'll be happy with brolucizumab at that stage. So if I have to do a graded therapy, I would start off with occult CNVM with aflibercept, and those who at the end of 3 injections have not resolved, those are the patients who I would now give their first injection of brolucizumab.
No, I think DT, this is totally agreeable. There's no doubt about the.
So I would not want to start off with brolucizumab as the first line treatment. And the answer is coming from Subhendu. The best way to answer is, तेरी आंख में तू क्या लगाएगा? या even better, ये one-eyed patient है, इसको क्या लगाएगा? One-eyed patient, treatment naive, would you start with brolucizumab? No.
Maybe. Right now.
So that answers the question also.
I want to put in another perspective.
Brolucizumab, Subhendu did say. One-eyed he said, but treatment naive he did say.
Yeah, that's what I'm saying. That, you are more aggressive when you say, oh, dusri aankh to hai na.
You see, my take on this is that as you give more number of injections, as you keep giving, experience of 600, 1,000 injections, then I think your vocal power increases regarding the injections. But having given, you see, people have given like Shubhendu more than 650 injections. So the confidence level of Disha is today at this pedestal. Whereas most of us are talking after giving few injections only.
Lalit, but if you look at the number of injections, the recurrences are occurring at 12 weeks. So you are going to need 12 weekly injections even with brolucizumab. So why not pick up the ones who really need brolucizumab?
I agree. Therefore, in the initial only I said, you see, for the patients who are in type 2, we agreed. In type 1, there, if patient, like you said, 30% may not be responding. So we should have an early switch. You see why I'm saying so? Two of my patients, you see, they had such a wow effect with brolucizumab. In fact, one was a high-fi lady and one was a principal actually. They said, Dr. Saab, why didn't you tell about this injection? 9 injections and 6 injections they had received of aflibercept. And we were persisting as if aflibercept is the total panacea and that is the best we have to offer. So when I gave brolucizumab, these were one of my first patients, total flattening with improvement of vision. So these patients ate my head out. Why we were not told about this? So what I'm saying is, counseling plays a very important role. You have no right to not to tell this patient that there is an agent available, special consent may be required. It's slightly more, IOI, but nevertheless, you can consider this treatment. There's no doubt. I'm talking of type 1, especially who do not respond to after 2 or 3 injections of ranibizumab of aflibercept. Yes,
Sir, I want to put in another perspective, sir. Now, there is a patient which Dr. Dinesh Talwar rightly said is responding to ranibizumab or aflibercept. So after the first 3 loading injections, through the year, they required total of 9 injections in 12 months to have that much visual acuity. had we shifted to brolucizumab in that treatment naive situation, probably this patient would require only 5 injections or 6 injections. So wouldn't that also be so when you say that the patients who are responding to ranibizumab and aflibercept, you will continue to put them on ranibizumab or aflibercept, and the patients who are not responding, they were the guys that you are basically going to promote towards brolucizumab. So if I have a newer drug in the market, which is a better drug, yes, there are some within inverted commas complications and side effects, which if we understand that if after this intraocular inflammation comes in, systemic steroids and topical steroids can take care of the situation, then I would consider brolucizumab. So the question that we need to answer here is, how severe is the complication that is there? How much problem? I mean, how many patients lost visual acuity because of that?
Gopal, the example you just gave, I told you, if the patient is requiring injections more than 6 weekly, you switch. You don't wait for the year now. Your time has changed. If you're in ranibizumab, if you're needing injections every 4 weekly or 6 weekly, you switch. If you're in aflibercept and you're needing more than 7 weekly, you switch. But if you follow this schedule, there will be 30%, 40% patients who would have been taken away. They won't need treatment. So you would save them from getting the risk of the inflammation that we're talking about. Now look at this situation. You have a patient who is requiring the injection once in 8 weeks. He's one-eyed. He's 80 years old. He's a diabetic. And you say, okay, let me give you a better injection. You'll need it once in 12 weeks. And he gets intraocular inflammation, which requires systemic steroids. Where are you now?
Dinesh, problem wohi hai ki all of us, have too much of scare.
No, I'm just saying this is a practical problem.
I agree. You see, if we scare or are concerned with the so much of this thing, we may not make inroads. What I'm saying is we should give this option. We definitely should give this option. Like you read, if patient is on aflibercept more than Q7 or Q8, we should definitely give this option of brolucizumab because of its better efficacy. Because today, you see, I'm still scared, although I have treated only 2 treatment naive with brolucizumab, and rest 21 eyes are of resistant treatment also. But believe me, I have not regretted. I'm not scared today. Inflammation hota hai. Because initially, first 2 injections, I used to follow up every day because the scare was so much by fellow colleagues as well as by inflammation. So I used to document. Day
1 and day 2 follow-ups with me.
I used to take photograph on fundus photograph just to tell media is clear. So you see, what I was saying was, as the number of injections increase, therefore the confidence level increase. You see, once you did the first macular surgery, the confidence level was this much. Once you have done 600 macular surgeries, the confidence level is different. So the number of injections makes all the difference. And that is the reason why your vocal cords become very loud and clear, that based on 650 injections, I am saying today that I have had 2 only this thing. And we, in any case, have much limited experience. So I think we should be open-minded and respect the experience of others also, what people have been saying.
I think the truth is in between. We need to become more aggressive.
Yes.
And they can continue the way they are doing.
Aging is catching on. You see, what I'm saying
Gopal can try more aggression than us.
No, there's no doubt when finish Gopal.
I have less brolucizumab, sir.
No, when Shubhendu said it's a miracle drug and you see it responds, and Braille study, then so many other studies have come out. So today numbers have to come up. You see, number and data collection will add confidence. Yeah. So that is why we started with Razumab. We started in a very small way. People never used to give. We started. Ultimately today, Razumab and Eccentrics have become interchangeable. We hardly differentiate. So same is true for this. As the volume will increase, as the numbers will increase, tomorrow DT will, once DT gives 600 injections, he will speak more loudly than Shubhendu.
Incidentally, Lalit, there was this patient whom Prashant had shown with a scar with intraretinal cysts, whom he said that we thought it was degenerative.
Yes.
Let me tell you, I have patients
left
like
eye,
this.
left eye, fellow eye. No?
Yes, I have patients like this whom I have been treating with intermittent injections. They have a scar on top. Every time I write for their prescription, I have to write that in view of useful vision injection being given, the cysts always respond to treatment with ranibizumab. And for 3 months, I don't need to give the injection after that. The point I'm trying to make is, because in your mind, people have this thing that cysts above a scar are degenerative, they have not been treating them. Actually, you do not define a cyst as degenerative till you've given a trial of treatment with ranibizumab at least.
Correct,
Forget about brolucizumab. So you're willing to give a trial with brolucizumab, but for 4 years you never gave a trial with ranibizumab. So that's
I have also one same cyst sitting on the scar, but I gave brolucizumab and this lady is very excited.
Yes, but it would respond to ranibizumab also. That's what the point I'm trying to make. I have been treating these routinely with ranibizumab, and most of them disappear. And sequentially, I can show you the effect lasts for 3 months or so. So please don't think that only brolucizumab is working. See, what is happening is you're suddenly jumping in patients who were not being treated to brolucizumab, saying maybe this will work. But at least have you tried ranibizumab for them? Have you tried aflibercept for them? If they have not responded, I can understand you're saying I tried. Like I showed you one lady who had these multiple cysts. She had got aflibercept for 12 injections and she did not respond. But with brolucizumab, after the second injection, the cysts became better. They became less. They still didn't go away, but they became better. Now there is a different situation. For me to say
that is 100% agreeable.
But do not say brolucizumab worked. But have I never tried ranibizumab?
Yeah. One is a aggressive approach. One is a careful approach. So that is the difference between Shubhendu and DT and this thing. I think we will now close it because we have, this is unending kind of discussion and debate which will go on. But my last words is all of us should collect experience and respect other people's observation who have huge amount of data and learn something, like you said, even from Gopal and everything. Question is, who is having more number of patients? So Gopal, it was a very exciting Sunday morning. Yes, and this AMD conceptualized by AMRITA under aegis of COC and KSOS, and which kept me glued for 4 hours to this chair. And we had some very, very good, take-home messages right from Pooja to Prakash to Vasumati, Natasha, Neha, and Rehana. Then DT and Prashant, they added icing on the cake and made this session very, very lively. So excellent. Congratulations to Gopal and Amrita and Cochin, COC, as well as.
And also thanks Shubhendu for increasing your confidence.
Yeah. So that is what. So with this, I think, Gopal, we thank all the speakers for sparing time for the benefit.
Yeah, so I was going to give the official Thanksgiving, but then Dr. Lalit Verma has already thanked everyone, so I don't think I should thank everyone again. So thank you very much, Dr. Lalit sir. With you as chairing the session, I know that the discussion will find direction and the discussion will be very fruitful. Thank you each and every one of you. And Dr. Lalit and Dr. Dinesh Talwar and Neha, Prakash, Vasumati, and my own local faculty, Natasha, Pooja, and Rehna. I thank you all very much.
Excellent.
And I also thank Novartis for actually helping sponsor this session. Thank you very much.
Thanks a lot, and hope to see you soon physically.
We have actually, sir, we have more than 316 views now. So that's quite a good thing for an age-related macular degeneration. The take-home was very good.
See, nowadays, Gopal, if I may honestly tell you, the number of views in routine webinars is sometimes single-digit or double-digit also. This is from AIS office, I'm telling you. So if you have 316 views, you should